started. Because I'd like to see if we definitely should be able to get through the rest of this chapter today and see if we can begin the elbow forearm before we finish up today. Okay, because I want to see if we can kind of pick it up a little bit without rushing. Okay. So we left off here. We finished talking about the sternoclavicular joint, and now we're talking about the acromioclavicular joint, which is a synovial joint. However, we refer to it as a plane joint because the articular surfaces are relatively flat. Okay, that's why we refer to it as a plane joint. And as a result, it's got 3 degrees of freedom. It's very easy to get a lot of motion out of this joint. When it says variable presence of an articular disc, again, that can be congenital. There may or may not be an articular disc in your AC joint, and over a period of time, that disc may degenerate, just like we see in a lot of other joints. And by the way, anybody know what the most common cause is of a supraspinatus tear? I shouldn't say common cause. Sequelae. You know what sequelae is, right? Something that, an accumulation of things that leads to something. That's when we say sequelae.
Like abutment of the tendon against the AC.
Nope. Degenerative. It's the most common sequelae that we see is a degeneration of that supraspinatus tendon. And it happens often in people later in life. And obviously, there may be contributing factors to that, okay? Depends on how much you're using that shoulder, for example. What is that shoulder? What kind of stresses is that shoulder subjected to? You know, in my case, very common in people in their 60s. That's me. And if somebody has used that extremity a lot, I'm left-handed. It was my left shoulder. I played a lot of squash when I was younger. So there's a lot of, you know, micro trauma to that tissue. But same thing can happen in an AC joint. And especially all that can be accelerated if there's any injury to the AC joint. Right? So that disc may or may not be present, and it can degenerate over a period of time. And this is just an illustration, I'm sorry, I skipped over, the most significant ligaments that we see associated with the AC. Superior and inferior acromioclavicular and the corticoclavicular ligament, which we also said is significant in what other condition? Corticoclavicular. We mentioned another condition that we also often see associated with that ligament. I think I heard you say it. Thoracic outlet syndrome. Right. I'm sorry?
Was it corticoclavicular or costoclavicular?
I'm sorry, costoclavicular. I'm sorry, I misspoke. Yeah, costoclavicular. Good catch.
I just thought I was going.
Good catch. Good catch.
So repeat that one more time. So there's a lot of like.
The costoclavicular joint is often associated with thoracic outlet syndrome because, again, we're talking about traversing between above the first rib. Okay, so that's where we can get entrapment. But this is just, again, an illustration of those ligaments that we just referenced. Okay. So again, if we talked about, and this is in advance of your practical, again, when I ask a question such as, what attaches here? There could be more than one answer. It could be a tendinous attachment of a muscle, of a specific muscle. It could be a ligamentous attachment, in which case you would want to be able to name, well, what ligament? There may be more than one ligament. That's fine. Okay? Just as an example. If we look at the arthrokinematics of the AC joint, the osteokinematics of the AC joint, there's about 25 to 30 degrees of upward rotation in an AP axis. Okay, so in that anterior-posterior axis, we can get some upward rotation of the at the AC joint. There's a small amount. We said there's 3 degrees of freedom here. There's a little bit of medial lateral tilt along the superior-inferior axis, and a bit of AP tilt on a medial lateral axis. Okay, so that's our 3 degrees of freedom at the AC joint. Most of it is that upward rotation. This is just a very nice little video that I would really encourage you to take a look at can be really difficult if you just, hopefully this opens. There we go. Urinary control? No.
Can I tell us something?
Okay, well, that link that's interesting.
Maybe it's a commercial.
Maybe it's, oh, here we go. Okay. So this is just, I'll send you the proper link. That's weird, it was working last time I tried it. Let's try it one more time. It's just demonstrating the osteokinematics, not just of the AC joint. Okay. I'll send it to you. It's a good little video that helps you illustrate, or helps you to really see when we started talking about that rotation of the clavicle on the sternum.
It works on,
It works on yours?
yeah, so,
Okay. So
just watch.
everybody can open it?
Yeah.
Okay. Very good video for you to take a look at.
It's pretty cool.
Okay? Because again, if we're describing these motions in words, it's just not going to sink in. So if you can actually see what's happening and observe what's happening at the sternoclavicular, at the AC, at the glenohumeral joint. Okay, you can slow it down. Okay, you can reverse it. Very good video for you to study from. Everybody able to open it? Yes? Okay. Yeah.
So when you talk about upward rotation, it's going this way and not this way.
Yes, correct. Upward rotation of the scapula.
Okay.
Right. Right, exactly. All right, so, and again, that video is very useful, not just, even though I stuck it in where we're talking about AC joint motions, it's really good for showing all the shoulder motions and all three joints, SC, AC, and glenohumeral. If we look at the scapulothoracic joint, we already know it's a pseudo joint, right? One of the most significant things about the scapulothoracic joint that we need to be aware of is the presence of the subscapular bursa. Okay, what's the role of bursae, plural? And this is going to come into play when we're talking in our lab today. We start talking about differentiating different types of pathologies of the shoulder. What's the role of bursae, or of a bursa in general?
Cushioning.
Cushioning, anything else? Reducing friction, right? Yeah, exactly. So it's between tissues, okay? Often between muscular and bony tissue. It can also be between muscular and muscular tissue, such as in the scapulothoracic joint, okay? And those bursae, or a bursa, can become inflamed, we call bursitis. And differentiating where pain may be coming from can be very difficult when we're trying to differentiate muscular pain, tendinous pain, and pain originating from a bursa. We're going to talk about that in the lab, how we can better differentiate that, yeah.
Just for terminology, what is the difference between tendinitis and tendinosis?
Well, what does tendinitis mean?
Inflammation.
Now, we're going to talk about this in the lab,
Okay.
but any itis means inflammation.
Tendinosis.
Tendinosis means some unusual processes occurring in this tendon. So, for example, if a tendon is compressed in something like an impingement syndrome, right, a subacromial impingement, is that tendon automatically inflamed? No. If it's inflamed, it's inflamed, right? If it's inflamed, we would describe that as a tendinitis. Tendinosis means there may be excessive pressure on that tendon that could be restricting motion or could lead to inflammation. That means osis means process. Itis means inflammation. Okay? We can't say that something is inflamed just because we think it might be. Because we see specific symptoms that are associated with inflammation, right? Like what?
Heat, hot
Heat,
temperature, redness.
redness, right? Edema, pain, right? But if somebody just has pain, does that automatically mean there's inflammation? No. So a more proper term to apply to a process, an abnormal process, is osis, tendinosis. So in most current literature, you're probably going to see reference to tendinosis rather than tendinitis. Okay, we're making a presumption that it's inflammation when we say tendinitis, and we don't necessarily know that that's true. Okay. If we look at the function of the scapulothoracic joint, again, we've said the stability of the scapulothoracic joint is necessary to have full motion of the glenohumeral joint, the upper extremity, right? It's to help stabilize so that we have that distal movement. All right. So it really needs to maintain a proper relationship, stability, so that we get the ideal length tension relationship of all the cuff muscles and specifically the deltoid as well. It's also the role of this joint is to make sure that the glenoid fossa is properly positioned for the humeral head. Again, to allow full normal motion. Okay? That joint, scapulothoracic joint, which is primarily held by muscle, right? It's not like your other joints, that's why it's a pseudo joint. It's not stabilized by ligamentous tissue, it's stabilized by muscle tissue. Because muscle tissue can absorb force more easily than ligamentous tissue. Ligamentous tissue absorbs force too as well. But it's to absorb shock through that upper extremity. Okay, again, what term do we associate with absorbing force? Type of muscular activity. Not producing force, but absorbing force. Eccentric. So we know that these muscles surrounding the scapulothoracic joint, in order for the entire shoulder complex to function normally, there must be an ability for those muscles to absorb eccentric force. Again, we're going to talk about that in lab, because what was that exercise device that you've already used in lab that we said is really good for training eccentric muscular activity? The impulse, right, the impulse. Now you can use lots of different exercises to target eccentric muscular activity. But again, that's very different than training concentric muscle activity. What was the other device that we used where we could actually test eccentric muscle activity? The Biodex. And again, that's a brand name. Technically, that device is called, it's the Biodex System 3 multi-joint system, if you really want to know. Biodex is the name of the company. You'll see it generally referred to as the Biodex, just like the other devices you'll see referred to as the Cybex. Cybex is the company. But technically, that's a System 3 multi-joint system. But again, it's a way of testing and assessing eccentric and concentric muscle activity. Okay? So those devices can be very useful, especially when we start looking at the ability of joints to stabilize or absorb force, and particularly the scapulothoracic joint, because it's so heavily dependent on normal muscle function, okay, to allow full shoulder complex function. Okay? And again, the movements at the scapulothoracic joint help to complete and enhance total shoulder range of motion. It's necessary for total shoulder range of motion. And it's also important for, if we're trying to stabilize distally and still have movement proximally, we're going to depend on the scapulothoracic joint, where we said one of the activities you guys are doing was a sitting push-up, okay, where that's primarily a scapulothoracic exercise, okay? And that sitting push-up is certainly useful in certain ADLs and in certain patient populations, okay? So that scapulothoracic joint, which normally we might associate with stabilizing proximally to allow more distal function, well, we may be more dependent on that proximal joint, depending on that individual and what they need to be able to do for daily function. If we look at the kinematics of the scapulothoracic joint, there's about 60 degrees of upward rotation, half of that coming from the sternoclavicular joint, and about the other half coming from the acromioclavicular joint. We get about 2 to 10 centimeters of elevation. We get a lot more elevation than we do depression of the scapulothoracic joint. And in terms of protraction and retraction, again, we'll get about 10 centimeters of protraction in comparison comparison to about 5 centimeters of retraction. Okay, so a lot more protraction motion, a lot more elevation, and again, fair amount of rotation. All right? And in terms of functional activities, why do you think that we would perhaps have a greater amount of elevation than depression and perhaps a greater amount of protraction than retraction? How does it impact our ability to function normally? Reaching overhead, reaching across the body, reaching across midline, right? Makes sense, functionally, and from an ADL perspective. Okay. So, now we're moving on to the glenohumeral joint, which we know is not the shoulder joint, right? So again, if you get asked questions, not just on an exam, but in a clinic, make sure you're differentiating between the joints of the shoulder complex. All right, so we're talking about the glenohumeral joint, which most people will associate with the, quote, shoulder joint, which we know is a misnomer. We know it's a ball and socket joint, has 3 degrees of freedom, okay? Because of the nature of this joint, and when we get to the acetabulo-femoral or femoral-acetabular joint, that's a much more stable joint than this is. So why is it so unstable? Because of that flat glenoid fossa. Okay? So you've got a ball, half sphere, that's articulating with a very shallow socket. And that socket is deepened by the presence of the glenoid labrum. All right? And because, again, that large humeral head and a small articular surface, we have an inherently unstable joint. As a result, we have a very prominent joint capsule to try to create some more stability of that joint. This joint is heavily dependent not just on the passive restraints, such as ligament, tissue, and the joint capsule, but on the muscular active restraints as well. And if we have a deficiency in either of those, either a muscular deficiency or a ligamentous deficiency, an unstable joint becomes even more unstable. Okay. And again, we will look at testing for that stability in lab today. In terms of those passive restraints, the ligamentous and capsular reinforcements of that joint, we have a superior, middle, and inferior glenohumeral ligaments. We have a coracohumeral ligament, the long head of the biceps and triceps. Okay? These are active restraints, right? Because these are tendons of muscle. And the rotator cuff tendons themselves will tend to blend with the joint capsule. So again, you've got a combination of active and passive restraints of this joint, of the glenohumeral joint. And if we don't have the proper function of both the active and passive restraints, or the contractile and non-contractile portions, then we're not going to have proper stability of the glenohumeral joint. Okay? And again, this is a really important point, because when we start looking at exercises and rehab of various pathologies associated with this joint, we've got to pay attention to both the active and passive restraints. And again, when we looked at the impulse and various other forms of eccentric exercise, keep this in mind. What did we say is one of the reasons that eccentric exercise is more energy efficient? How come? How come? You remember. Why is it a more energy efficient form of exercise? Eccentric exercise. Energy efficiency, because you're not wholly reliant on the contractile tissue. Right, so these passive restraints can absorb that force. You're not totally dependent on muscular activity. So, if we got a joint where there is a lot of dependence on both active and passive restraints, and we have damage to any of those passive restraints, you should be able to understand why that can have such a devastating impact on function, especially eccentric function of this joint. You follow? Because if we're heavily dependent upon the non-contractile elements, and the non-contractile elements, which is bursa and tendon and ligament, right? If we're very dependent on those structures, and those structures are damaged, now that has a huge impact on the ability of the muscles around that joint to absorb eccentric force. And when we start looking at various sporting and functional activities, we'll see why that's so important to understand. Okay? So keep that in mind about this whole role of non-contractile passive tissues and their role in eccentric exercise. It's really important to keep that in mind. Another significant area which you've already talked about, the coracoacromial arch forms the roof of the glenohumeral joint. Okay? There is a space beneath that, which we call the subacromial space, which is between the humeral head, the superior portion of the humeral head, and the acromion, the undersurface of the acromion. Okay? And we also have present in this area the coracoacromial ligament. And when we talk about subacromial impingement syndrome, that's where this occurs. Impingement of which tendon? Largely supraspinatus. What also can be impinged there?
The biceps tendon?
Which
Oh,
one?
sorry. Long head?
Thank you. The long head, right. Long head of the biceps, yes. And again, if we have inflammation in this area, that would be a supraspinatus tendinitis or a biceps tendinitis, specifically long head of the biceps. If we just have compression, we would say what? Subacromial tendinosis, biceps, long head of the biceps tendinosis. The minute we start getting pain upon palpation or pain with movement, now we've got a classic sign that we can presume that there may be inflammation present. Right, now we got pain. And we're going to be doing some tests of that in the lab. All right. Again, the presence of bursae in the shoulder is really important to keep in mind because these bursae can be inflamed just like the tendon or muscle can be inflamed. And we refer to that as bursitis, right? There is a subacromial bursa, and there is a subdeltoid bursa. So where's the subacromial bursa? It's between what and what? You know. Between the acromion and the head of the humerus, right. So again, it's where we want to reduce friction. We want the ability to cushion structures that are between the acromion and the humeral head. Subdeltoid, obviously, therefore, is below the deltoid. All right? And that subdeltoid bursitis can often be confused with what? If somebody has a supraspinatus tendinitis, I don't know how much you've talked about this yet, but can you see a referred pain pattern from that?
Yeah.
Where does it often get referred?
Side of the arm presents a rotator cuff tear.
So can you see how we could certainly get confused between subdeltoid bursitis and a supraspinatus tendinitis? Yeah. So again, this points out the importance, especially with the shoulder complex. When we're trying to diagnose issues, PTs don't diagnose, right? We certainly do. We have to, right? How do we know what we're treating if we're not diagnosing what's wrong? But it's very common to confuse a subdeltoid bursitis with a supraspinatus tendinitis. Okay? Is it also possible that we could confuse other types of conditions with a supraspinatus tendinitis or a subdeltoid bursitis? Like what? Anybody think of an example? I know you can if you really think about it. Especially when I say referred pain. What do you generally think of when I say referred pain? Radiculopathy. Right, yeah, radiculopathy. Right? So, is this pain actually the result of a cervical radiculopathy? Or is it localized? Right? Points out the importance of what you've heard me say and what you'll hear me say over and over and over and over. We don't diagnose on the basis of one test. Even though you're going to be doing shoulder tests in lab, that gives you data. That's all it gives you. It gives us data. We get results of tests, and we have to add everything together. This rules out that. This implicates that. Right? Very important. Okay? If we look at the osteokinematics of the glenohumeral joint, abduction and adduction occur in the frontal axis along an frontal plane, along an AP axis, flexion extension in the sagittal plane, along the medial lateral axis, and medial and lateral rotation, which we also call internal external rotation. Both are proper. In a transverse plane along the superior inferior axis. Again, remember, always from the anatomical position. All right, this is all review. But again, it's making sure that we're putting it in, kinesiological terms. Make sure that I didn't skip over it, right? No, okay. If we look at the arthrokinematics of the glenohumeral joint, we've got a convex humeral head on a concave glenoid labrum. In flexion extension, what we're seeing primarily is spin. Okay? Remember from our exam definition of spin, one point of contact on one surface with one point of contact on the other surface. That's where we're getting primarily spin in flexion extension. In abduction, we're going to roll superiorly and glide inferiorly. Right? That's what we're seeing. And this is open or closed chain? Open, right? Open. Again, most of our functional activities in the upper extremity is open. Most of our functional activity in lowers is closed, right? Not exclusively, but mostly. In external lateral rotation, we've got a posterior roll and an anterior glide. Again, we've got a convex on a concave. And in medial rotation or internal rotation, we've got an anterior roll and a posterior glide. Okay? So when you're taking your exams, you'll be doing this all the time, right? Which is a very good thing to do, by the way. Okay? If I don't see somebody doing this, and they're just thinking, that's a mistake. You can always see PTs and PTAs taking exams because we see this all the time, right? Very easy to keep in mind. Don't memorize it. Don't even try to memorize it. Yeah.
So flexion, isn't the ball kind of moving posteriorly?
The primary movement that you're seeing, because remember, we've got this humeral head against this glenoid fossa. That's why you want to rearticulate your bones and really see what's happening. Okay, it is primarily spin. We've got one point of contact of that humeral head. Here's my glenoid. I can't move my arm this way, but that's the motion that you're seeing. And if you rearticulate your bones, you'll see you're maintaining really one point of contact on that humeral head with one point of contact on the glenoid
So
fossa.
it's not that there's not some posterior roll, it's that primary thing you're seeing is the spin. Because when I think spin, I'm thinking this, like it's just,
Yeah, but you're thinking this, that's also spin. That is spin.
so can you show me the
That's
posterior
also spin.
roll, what that might look like?
I'm sorry?
Can you show me what a posterior roll might look like?
Posterior roll means, first of all, we know that in order for the joint to stay in place, you have to have roll and glide, right? If we didn't have the glide, I'd be rolling right off the glenoid. If this is my glenoid and this is my humerus, that would be posterior roll.
Oh, it's
And
moving.
this is
Okay.
anterior, this is posterior.
Okay.
And if I did not glide anteriorly, I'd roll right off that glenoid. So I've got to roll and glide. I've got to roll posteriorly and glide anteriorly to stay within that glenoid. Again, it's the reason you want to rearticulate your disarticulated bones. It'll make sense to you when you do that. Yeah.
Is there a difference between spin and roll? Or, because,
Spin means one point of contact on each joint surface.
okay,
Roll means you've got a new point of contact. Think of a tennis ball rolling across this table,
Yeah.
right? There's a point on that ball that comes in contact with the table. As I roll the ball, a new point on the ball and a new point on the table.
And then-
As I continue to roll, another new point, another one, another one.
but spin is what now?
Spin is if I took that tennis ball
Uh-huh.
and I
Oh.
just spun it.
Gotcha, oh, got it,
One point of contact on the table, one point of contact on the ball.
got it, okay.
All right?
Quick question, Ally.
Yeah.
So for lateral medial rotation, is that, so that would be in 90 degrees?
Lateral and medial rotation. You said lateral medial rotation, that's two motions. Right?
And, yeah, lateral and medial rotation.
Mhm.
So that is describing when it's at 90.
No,
No.
no. Remember, everything is in the anatomical position. When we're describing internal external rotation, we're talking about it in the anatomical position. Okay? It's occurring in a transverse plane along the superior inferior axis.
Then if you're doing
But
that-
even if I do this, okay, you can see even more clearly that I'm moving in a transverse plane along the superior inferior axis. And whether I do this with the elbow flexed or the elbow extended, it's still the same motion as people in a humeral joint. It's still the same motion. It's easier to illustrate with the elbow flexed. Okay? All these motions, when we talk about arthrokinematics, remember, it always relates back to the anatomical position. Okay? Okay, the resting position for the glenohumeral joint, that's where we have, if someone has, whenever we're talking about in our peripheral joints, we talk about resting position, it's the position that someone's going to want to attain when there's dysfunction or pain within that joint. Okay, don't confuse it with closed pack and loose pack. Okay? It's where we're placing the least stress on that joint, all the structures around that joint. That resting position is in about 20 to 30 degrees of horizontal abduction and about 55 degrees of flexion. Okay? So bring her up to about 55 degrees of flexion, 20 to 30 degrees of horizontal abduction. If you see someone that's had a significant rotator cuff repair, you'll see them in an airplane splint in about this position, where you've got them about 55 degrees of flexion, 20 to 30 degrees of horizontal abduction. Okay, that's where they're going to be placed, because it places the least stress on those surgically repaired tissues. Okay? The closed packed position for the glenohumeral joint is full abduction and lateral rotation. Full abduction and lateral rotation. That's where we get the greatest, again, the greatest amount of bony congruency and the greatest amount of ligamentous tightness. In this case, also the joint capsule. Yeah.
All right, you said don't confuse resting position with loose pack,
Because how do we define the loose pack position?
anything but.
Anything but closed pack.
So
Right?
is this the most loose pack is the resting position?
No, because we're just looking at where there's the least amount of tension on the structures around that joint. Remember, loose pack also refers to the morphology of the bones. Okay, it's not just the shape of the bones that determine that resting position. It's where we're placing the least amount of stress on the soft tissues, exclusively the soft tissues around that joint, without regard to what the bone morphology is.
Yeah, whereas the loose pack is both the bone
Right.
and the soft tissues.
Right. And
This is
again,
just the soft tissues.
The most important thing to know is the closed pack position for these joints, because any other position other than closed pack is an open pack position or loose pack position, right? The other significant area that we obviously need to be familiar with, and which we're going to be looking at in lab, is the bicipital groove, which is also called what?
Intertubercular.
The intertubercular groove, right? Synonymous, which is where we see which head of the biceps? The long head of the biceps runs through that groove, and it's restrained, it's held down, held in place by the coracohumeral ligament and the transverse humeral ligament, okay? So if either of those ligaments are disrupted, or both of those ligaments are disrupted, it's very easy for that tendon along the head of the biceps to move out of that groove, okay? Which is something that we can see in some patients. And again, just like we said with supraspinatus tear, rotator cuff tear, specifically supraspinatus, this often happens as a result of degeneration and repeated stress over a period of time, repetitive stress, damage to these ligaments, which can then lead to disruption of that long head of the biceps. And again, you can get that snapping of that tendon in and out of the intertubercular or bicipital groove. Okay. During motions of the shoulder, that humerus is moving underneath that tendon, that long head of the biceps, right? There's movement of that humerus beneath the long head of the biceps tendon. So again, we can get wear and tear on that tendon over a period of time with repetitive motions, upper extremity motions, and we can get degeneration of that tendon. Okay? So again, that tendon can wear down with repetitive stress over a period of time, and the long head of the biceps tendon can also be impinged, just like the supraspinatus tendon. Okay, beneath that subacromial arch, within the subacromial arch. We know that in order for normal motion, oh, sorry, question?
Oh,
no. No question.
Oh, no.
Okay. In order for the normal shoulder complex motion to exist, there needs to be a normal scapulohumeral rhythm, movement that's occurring at the scapulothoracic joint, and movement that's occurring at the glenohumeral joint. Okay, and generally speaking, once we get beyond the first 30 degrees of elevation, there's about a 2-to-1 ratio. There's twice as much glenohumeral motion as there is scapulothoracic motion. Okay? From 120 degrees to 120 degrees, from about 60 degrees, the glenohumeral motion, we're seeing that most of that motion, about half of it, is coming from the acromioclavicular and the sternoclavicular joints. Okay, we can't forget those joints when we look at total shoulder motion. And we say there's a migrating axis of rotation, it's moving. Okay, because we've got movement occurring at the scapulothoracic joint and movement that's occurring at the glenohumeral joint. Okay, so that axis changes. Because again, we've got a concave scapula on a convex thorax, and we've got a convex humeral head on a concave glenoid. So you've got movement that's occurring at both joints. You can understand how that axis of motion is going to be changing. Right? You've got a different morphology of these joint structures and these joint surfaces. Okay? We've already said that that scapulothoracic joint needs to stabilize for normal distal function, for normal motion of the glenohumeral joint. And all of these muscles help to stabilize the scapula. serratus anterior, trapezius, rhomboid major and minor, the pec minor and levator scapulae, plural. Okay? So these are all muscles that help play a role not just in total shoulder motion, but stabilizing the scapulothoracic joint. We've already talked about that the shoulder complex is heavily dependent on both active and passive restraints to maintain the integrity of this joint because it's an inherently unstable joint, glenohumeral joint. The cuff muscles play a great role in, again, maintaining stability of that glenohumeral joint. Specifically, supraspinatus, infraspinatus, and teres minor, subscapularis, and the biceps and triceps brachii. These are all stabilizers, active stabilizers, which is, what's another word we use to describe that type of stabilizer? Passive restraints are static stabilizers. Active restraints are dynamic stabilizers, right? Okay? Why is that so important? Okay? If you're hitting a tennis ball, or hitting a baseball, or catching anything, you're working on a loading dock, and somebody's tossing something to you, and you're catching it, which happens all the time. If anybody's ever worked on a loading dock, you can tell you it happens all the time. I've done that on my summer jobs. You're not just going to walk over and hand it, because it takes too long. You're going to toss it. Right? So I'm catching things, I'm absorbing force, right? Those muscles have to contract to stabilize my glenohumeral joint. They're contracting eccentrically, largely, as I'm catching. They have to stabilize my joint. I can't just rely on those static stabilizers. I have to rely on my dynamic stabilizers. Okay? Extremely important to have a good grasp of this. Okay? The role of these cuff muscles, yes, they are used to initiate movement in abduction. Okay? They are used to help complete movement, total shoulder motion. But they play a very large role in stabilizing that humeral head and glenoid. Okay? And if I have damage to any of these muscles, I'm going to lose stability of that joint. I'll get a lot of abnormal motion. And what's one of the things that we see is associated with prolonged abnormal joint motions? What can happen to that joint over a long period of time? Abnormal motion of the joint. Things are just not, the joint is not stable, it's not moving normally over a long period of time, can't absorb force like it should, right? Because these muscles, these dynamic stabilizers have to produce and absorb force. What happens with joints over a period of time? What can happen with that, any kind of injury to joints over a long period of time? OA, osteoarthritis, yeah, exactly. Okay? So, again, we're talking about that sequelae. One thing leads to another. Okay? If we have abnormal function of dynamic stabilizers around the joint, it can be a precursor to development of osteoarthritis in that joint. Just like if we have disruption of static or passive stabilizers, we can also, that also can be a precursor to the development of osteoarthritis. Like, for example, in the knee, right? What's a passive stabilizer in the knee that can be damaged and lead to osteoarthritis over a long period of time? ACL, yeah, ligamentous. What's even more common? Meniscus, right. Meniscal tears, meniscal damage, loss of a meniscus, even a partial meniscus. I have like this much meniscus left in my right knee. Guarantee my x-rays would probably look really interesting. Had 2 knee surgeries and that's enough. So those cuff muscles are primarily glenohumeral stabilizers. Yes, they produce motion, but they're not the large movers like the larger muscles are. Deltoid, latissimus dorsi, teres major, pec major, and coracobrachialis. These are primarily the prime movers of that glenohumeral motion, all right? And again, those cuff muscles play a very large role in guiding the movement, the motion of the humeral head as those large muscles are generating force. So would it be fair to say that those cuff muscles are sort of postural muscles? Yeah, they need to be much more active over a longer period of time, right? So what do you think their primary muscle type would be? And don't jump.
Type 1.
Or
Type 2A.
type 2A, right? Yeah, exactly. So you're going to see a lot of 2A, because again, we said they also perform, they contribute to motion, right? They're not just absorbing force. Okay, they're not just postural muscles, they're secondary movers, right? So you're going to see a lot of more type 2A muscle fiber distribution in those cuff muscles. And a fair amount of type 1 muscle fiber as well, okay? So again, we've talked about passive stabilizer is the same thing as a static stabilizer. Our passive stabilizers in the joint, the sternoclavicular and AC joint, SC and AC joints, really rely almost exclusively on ligaments to support those joints. And the glenohumeral and scapulothoracic joint rely almost exclusively on muscles for support, okay? We know that at rest, that glenohumeral joint is really one of the few joints in the body, it's the only joint that is suspended in a standing position, suspended against gravity, right? It's held in that glenoid fossa by mostly muscular activity. Yes, there is some ligamentous support, right? Primarily that coracohumeral ligament providing ligamentous support, but it's heavily reliant on muscular support to maintain the integrity of that joint in standing, okay? It also relies on negative intra-articular pressure. So within that joint capsule, the pressure within that joint is less than it is in the atmosphere. That's why it's a negative pressure. In other words, it's a vacuum. Okay? So that's one of the things that helps to hold that humeral head in the glenoid fossa, is that negative intra-articular pressure. Okay? And that's always going to be present unless and until we allow the penetration of air, atmosphere into that joint. That's not going to happen unless there's a severe trauma to the joint. Okay? The clavicle and the scapula really are resting on the thorax. We've already talked about that. Okay? Even though they're part of the shoulder complex, they are really just at rest on the scapula. If we look at the dynamic stabilizers of the scapulothoracic joint and the glenohumeral joint, we've already mentioned specifically the scapulothoracic joint, serratus anterior, right? The upper trapezius has a little bit of activity at rest, okay? The cuff and the biceps, again, we know are those dynamic stabilizers, all right? In order for us to get the normal scapulothoracic, scapulohumeral rhythm, in order to get full shoulder complex motion, we know there's got to be synergistic action between all these muscles in the shoulder complex. The upper and lower traps and serratus have to be active to allow for full upward scapular rotation. For full downward scapular rotation, the pec minor, levator scapulae, and the right rhomboids need to work synergistically to allow for that downward rotation. Shoulder elevation simply means it's not pure flexion, it's not pure abduction, it's not pure scaption. It's just elevation of the arm above the shoulders, elevation of the upper extremity toward the ceiling. So elevation is a non-specific motion. And that requires activity of the deltoid and the cuff. They need to work synergistically to allow for that motion. Yeah.
Whenever you have upward rotation, you always have shoulder elevation.
Upward rotation of the scapula.
Right, so if my scapula is upward rotated, will I always have shoulder elevation? at the same
No, we're
time?
simply talking about to allow for that scapular rotation, we need the proper force couple between the upper traps, lower traps, and serratus. We're not talking here about granulum. We're just talking about the motion that's necessary at the scapulothoracic joint.
Okay, maybe I'm not asking it the right way. So can I upwardly rotate my scapula without elevating? Am I asking it the exact same question?
But elevation of the scapula is different than upward rotation of the scapula, right? It's a different axis of motion.
Elevation is superior, inferior.
Right,
Upward rotation.
and you're in the
is-
frontal plane.
Is,
If we're just upwardly rotating, right? Your axis of motion is AP, okay? If we're elevating and depressing, your axis of motion is superior, inferior. Okay, if we look at the activity of these muscles during, again, when we say shoulder elevation, we're simply referring to bringing the upper extremities above shoulder toward the ceiling. We're not talking about specifically flexion or abduction, okay? When we're elevating from about 30 to 60 degrees of pure abduction, the supraspinatus, we already know this, has a greater amount of leverage than the deltoid, okay? So in that 30 to 60 degrees, we're going to see a lot more activity in the supraspinatus. As we get above 60 degrees, now the activity changes. We see much more deltoid function, deltoid activity, and we do supraspinatus. Okay? The lever arm length for supraspinatus really remains constant throughout its range, but that lever arm for the deltoid is going to change, which is why the deltoid becomes more prominent as we get greater amounts of elevation. That's why the deltoid is going to become a more effective mover of that humerus as we approach greater amounts of elevation, as we get above 60 degrees. Okay, because it's achieving a greater mechanical advantage. Earlier in the range, supraspinatus has a greater mechanical advantage, that's why it's more active. Deltoid does not have a good mechanical advantage, so it can't perform as much of that motion. It's not until we get about above 60 degrees that we see the deltoid kicking in more. Again, remember we talked about when if we're testing isokinetically, and I'm hoping that we can get the BioVex working properly this semester so that we can actually see these torque curves. But we said that we're measuring, torque is a measure of what type of force and what kind of motion? Rotary motion, right. So if we look at rotation and we're measuring the force being produced during that rotation, we measure it in foot-pounds. Okay, we measure it in torque. If we were to look at your ability to generate maximum force, and we're going to look at this with the large joints in the body, but specifically shoulder and knee, because that's so important, we're going to see that the internal rotators are stronger than the external or lateral rotators by a ratio of about 3 to 2. Okay? Meaning that, for example, if I were to test your strength in internal rotation, let's say you could generate 60 foot-pounds of torque. If I were to check your strength in external rotation, how many foot-pounds would you generate? 40. Right, exactly. So they're not twice as strong, but the internal rotators are significantly stronger than your external rotators, or medial rotators versus lateral rotators. Your adductors are about twice as strong as your abductors. Okay? So you're about twice as strong into adduction if we were to test you isokinetically and check, see how much force you could generate, we'd see about a 2-to-1 ratio of your adductors to your abductors. Extensors, again, the ratio is about 5-to-4. So again, if you could generate 100 foot-pounds of torque in shoulder extension, how much shoulder flexion force would we generate? 80, right. Okay. So, why would that seem to make sense? Isn't this anti-gravity, right? Abduction is anti-gravity, yes. Flexion is predominantly anti-gravity, yes. Now rotators, no, you're pretty much staying within. You're not anti-gravity movement. Kind of gravity reduced, not gravity eliminated, but gravity reduced. Why would we need greater strength, internal rotation, adduction, and extension? Can you think any functional reason why that would be the case in humans? Internal rotation, adduction, and extension. That's where my strength is.
Climbing.
Well, you don't climb on your hands unless you're a really good acrobat.
Sit, stand.
Standing, yeah, pushing off. Absolutely, right? Now, obviously, depending on maybe what you do for a living, or if you play a particular sport, or you're targeting in weight training, you're targeting these other muscles, well, yeah, you're going to change those ratios. But normally, that's where your greatest amount of strength is going to be. You need those muscles to push and arise from a sitting position, even if you don't have to use your arms. You know, that's what you're going to use them for. So it makes sense from a functional perspective. Okay. We also know that there's a lot of complex movements that are necessarily for me to wash my hair, comb my hair, brush my teeth, right? It's a combination of movements, and I need to use a lot of different muscles to achieve that movement, to achieve that position. It takes different amount of strength and muscular activity to pull or push an object, right? So we've got to understand what's necessary in terms of joint movements and muscular function in order to perform different activities. We're going to talk about that more later in the semester. Okay. We know that if there is any weakness or impairment of the serratus anterior, we will lose some of our ability to upwardly rotate the scapula. We know one of the more common injuries that leads to that is an injury to the long thoracic nerve. And if there's disruption of that nerve or severing of that nerve, that will cause palsy of the serratus anterior, but we'll call it a long thoracic nerve palsy. Okay? If we have damage to the spinal accessory nerve, we'll see involvement and perhaps a palsy within the trapezius. And that will really severely limit our ability to elevate the scapula, shoulder elevation. Hopefully you don't see a lot of these types of nerve injuries in practice, but it can happen. I have this vivid memory of one of the worst shoulder injuries I ever saw was a guy who was a night watchman in a factory. And he got robbed. A couple of guys broke into the factory, told him to lay on the floor, as you would generally do, as they started to pilfer stuff from the factory. The warehouse, I guess it was, really not a factory. Before they left, he's laying on the floor. Before they left, one of the guys put his foot on his scapula, took his arm and just pulled it. Completely severed the entire brachial plexus. Right? Horrible. There was no reason to do it. Well, they did. So you talk about somebody that had severe impairment in the shoulder and multiple palsies of the musculature in the shoulder complex. It's terrible. Terrible.
I got them.
Never going to recover from that. So again, just in summary, we understand when we talk about the shoulder, it's not glenohumeral joint, it's multiple joints, it's 3 joints. All right? 3 real joints and 1 pseudo joint. All right, that's scapulothoracic. That shoulder has to provide for a lot of range of motion for normal function. Okay? That glenohumeral joint is a very unstable joint, and it's heavily reliant on dynamic muscular activity, and again, we're going to look at that in the lab, in order to provide the stability that's necessary. And total shoulder motion has to result from all these force couples, normal function of the muscles around both the scapulothoracic and glenohumeral joint. They've got to be functioning properly, they've got to be properly synchronized. And if we see a breakdown in either the passive or dynamic restraints, static or active restraint, right, we'll see an impairment in various joints within the shoulder complex. Because we got this really complex interaction of these active and passive structures, if any one of them breaks down, it has a major impact on overall function of the shoulder complex. Okay? All right. Yeah, I'm not going to bother starting with the elbow yet. All right? Any questions about that? I mean, the takeaway is, again, remember, we're going to be looking at this again in our lab, not just looking at various special tests of the shoulder, but thinking about if we're trying to increase eccentric strength, eccentric function of these dynamic stabilizers, what kind of things could we do with our patients, aside from simple PREs? All right. Okay? See, oh, by the way, Wednesday, if you think this semester is nuts, last year, we had kinesiology lecture in here, and our lab was over in the gym building. Okay? Until about halfway through the semester, we got moved from the gym building to the 4th floor multi-purpose room here. And then, as you'll remember, towards the end of the semester last year, we went remote. So this is a piece of cake compared to last year. But Wednesday, we will be in the nursing computer lab on the 3rd floor. You know where that is? It's as soon as you're going into the Center for Health Sciences on the 3rd floor, on your left. That's the nursing computer lab. That's where we're going to have lecture on Wednesday. Okay? On Wednesday, this Wednesday. So we won't be here, we'll be up there. All right? All right, we'll see you downstairs.
Semantics. You say tomato, I say tomato.
Well, what would that be called though, if,
It's the difference between right and wrong. What's that?
what would you be called, what would it be called if you were pushing down into the hips, down? into
Even if I'm pushing from the knee into the hip, that's still approximation.
No, from the ASIS down as they're trying to come up, that would be, it's like a resistance.
Well, if they're pushing up, then yeah, that'll be some type of
No,
resistance.
Not rhythmic initiation.
No, that's passive first, followed by active assisted, then active. All right, number 7.
C.
C. 8, what's 1?
B.
B. 2.
A.
A. 3.
C.
C. Number 9.
Yeah, that was-
Can you go back to, I'm sorry.
Yeah.
1B, 2A.
3C. Number 9. So what occurs at stage 3 of Brunstrom's model? Yeah. So that's when there's stage 1, placidity, stage 2, the beginning of flexor of the synergy. Stage 3 is full synergy. So what we're looking to do is, okay, how do I break that synergy? Best thing would be is by certain positioning of the patient, weight-bearing activities to help minimize spasticity. So that would be the best at stage 3. yes. Yeah. A.
C.
Ten,
Shove S in or zero.
that would be D.
What is it?
D.
D.
I just wanted someone to talk.
That would be D. So let's see, 3 days post-op, stepping forward. So what do you do, 3 days post-op? What's the acute stage? Function, but obviously function for this patient, 3 days post-op, would just be, like, I'm not worried yet about stepping forward. You know, maybe sit to stand, maybe some weight shifting. So certainly stepping forward, you know, eventually you get that. It's a treatment you can do for this. But in the early stage, at the acute stage, that's the least of our concerns right there. 11,
B.
B.
You said the answer would never be MCA.
Maybe not.
You said it would.
I know I said.
He lied to us.
Confusion
He
again.
lied to us.
Right, so that's A. I mean, B.
He did that SDA.
11.
The answer is B.
Yeah, anterior cerebral artery. 12, smoking, diet, obesity, exercise, blood pressure. 13. 13 is A. 14,
C.
that is correct. 15,
Can you go back and just,
13 is A. 14 is.
C.
14 C.
all right. What was the 13th question? I was looking
How
at.
do you guys know what
Okay. All right. And then C.
Right? 14 C. 15,
I mean, sorry.
A. Trigeminal.
Yeah.
16, upper motor neuron lesion, which of the following not A, 16A. 17,
C.
C,
what was 15?
15's A. 18,
D.
B,
So why would, so basically stage 2 and 3 are similar in that you want to start increasing this type of activity so it eventually comes out of that flexion.
so when we're starting to see the emergence, A and C bring us into the flexor synergy. We don't want to promote that.
Okay. No, I was just asking because the other question asked about stage 3 and it was also weight bearing.
Yes.
So you want to start promoting that weight bearing and that coming out of that position.
Yeah, you're gonna see a lot of, you know, for position, for exercises, a lot of times it's a weight bearing approximation with neuro, you see a lot of that. 18, you good, all right, got that. 19,
D.
19 is D. 20,
C.
C. 21, D. 22, Z.
It's C, huh? Wait, so,
What was 18?
Wait, peripheral nerve injury, what kind, is that an upper or lower motor neuron lesion?
lower,
What does the lower motor neuron lesion give us?
Thank you, Joseph.
a loss of sensation and then some, numbness.
What else? No. It will, but lower motor neuron lesion, as per the slide.
Well, I guess it gives us braces.
Hypertonicity or hypotonicity?
Hypo, and.
Hyperreflexia, hyporeflexia.
Hypo. So, muscle fasciculation, that's just a twitching?
Yeah, it's a twitching.
That was shown here.
Oh, would you not get that with the lower motor neuron?
That's-
I thought that's what
Yeah,
you
Would
like
you not?
placidity, so like a lot of.
Right, you would have,
I'm just saying, I thought I read that happens too. For circulation.
fasciculations. But there's some, there's motor involvement there.
Yeah.
So with C, paresis. 23.
B.
A.
I think I'm gonna get it wrong on the test.
You
just
will,
for
I'll make
laughs.
sure of it.
No, just for laughs.
24.
C.
C. 25.
C.
C.
25 is C.
Wait, what was, 24, I'm sorry, 23 and 24?
23A, 24C,
Okay.
25C, 26.
B.
I got B.
B. B, 27.
B.
B. 28.
Go back to
We're gonna get, all right, let's see that again.
Did A?
Sorry about that.
Did A?
28 is A. 29, scapula is what? Sorry, the beginning part, the beginning. Anterior depression. Glenohumeral joint is internal rotation, adduction. It's actually extension, but yeah.
What was the scapula?
Anterior depression.
So,
So we're starting here, in and out. Starting D2, finishes with posterior elevation.
Oh, wait, beginning components of movement, this is done.
The beginning component, that's where I start, that's the beginning part, that's where I start.
So it's asking,
It's basically asking, where do I start? What's occurring at the scapula and the glenohumeral joint at the start of,
anterior depression.
yeah, that's what I said, anterior depression.
No, I know, but, okay.
Of the scapula, glenohumeral joint is internal rotation,
Posterior elevation, because
that's where you end. We're starting, we're performing flexion, start here. The beginning part of D2 flexion is here. The ending part of D2 flexion is here. The beginning part of D2 extension is here. The ending part of D2 extension is where
this
D,
is the beginning part
Yes.
of D2 flexion.
yes.
So this would be the beginning of D2 extension,
Or,
or the end of the D2
D2
flexion.
flexion.
Very simple.
and 30.
D. Oh. D. That's just.
So all it's saying is through the shoulder, widest, largest base support, so it's gonna be C.
Yes.
Front elbows.
What's plantar grade?
Plantar grade is this. Like standing up against, leaning against something.
C or D?
C. Doesn't say anything about the hips. Does anybody know what this is? What this is called?
Pronation, supination.
What's it called? The inability to do pronation, supination, or rapid alternating movements.
the inability to do.
Yeah, what's that called? Anybody know? Dystidocokinesia.
I'm sorry. I think that one.
Dystidocokinesia.
Is that on the test?
Yes, it's on the test.
Is it actually?
Yeah, it is. It is.
Could you spell that
It
for me?
is. Maybe.
Could you spell that for me?
Dysdiadocokinesia. Dystidocokinesia.
Can you spell this time backwards?
Dystidocokinesia.
That's a
CHO? Don't go CHO.
actually an answer to the question on the test.
Yeah, Aries, like there's certain parts.
We didn't even talk about
Nah, that's why I bring them now.
You'll just remember.
Yeah.
You can't remember that.
Yeah, so it's inability to perform opposite, rapid alternating movements. Dystidocokinesia, that makes sense.
Honestly,
CHO,
if
you're
you
right.
see that on the test, I'm gonna
Yeah.
go with it.
You guys will be fine.
Any questions for the test?
Yeah.
Right.
Look at 28, you said.
We're gonna do it in lab, right? Same question again, lab.
So it's the inability to do
Alternating, rapid alternating movements. Pronation, supination.
got it.
Pronation,
But what if,
supination.
like, if, I mean, like, what if you just can't do it, like, as a normal human?
Then looking at the anatomy, so a lot of the stuff we saw today, upper motor, upper versus lower. The motor, the spinal tracts.
Trying now.
See, you're doing a good job. You don't have any neuro impairment there. No brain injury on your way in this morning. In terms of like the pediatric stuff, cerebral palsy, the different types. Duchenne's muscular dystrophy. Just, it's sort of like the progression. You know, for osteogenesis imperfecta, what don't we do? Stretch. For spina bifida, like the differences of, Colta, myelomeningocele. And then there'll be some functional stuff with spina bifida, which if you know your myotomes, you'll be able to answer those questions. For our Down syndrome patients, what don't we do? So cervical work, but like the gym class type stuff. No. Yeah, contact sports, tumbling, diving, stuff like that. Don't dive into the pool. So obviously you're gonna know the axial instability. That's your pediatric section. For CVA, go back and just take a peek at the Circle Willis. Know your different categories, middle cerebral, anterior cerebral artery. More of just how they present. The Brunstrom, that'll certainly be on there.
Risk factors. Like the most important stuff for the CDA lecture, that's 54 slides.
Synergies, right? The PNF, so know what position you're in, but also know the other definitions, rhythmic initiation.
We tested on like most of the stuff in that second CVA PowerPoint, like positioning and acute care and all that stuff, like rehab and all that type of stuff.
So, yeah, however, those are just, like when it comes to the exercise,
Yeah.
like a lot of that stuff just, when you read everything over, it just becomes like common sense.
Yeah.
And I hate to, say it's common
I mean,
sense.
it'll be like this, where it's like, 3 days.
I will never ask a question like, 3 days, 7 days post-op, your CVA, what exercise, there'll be,
I mean, there was one in here, like, what would be the least appropriate 3 days post? It would be something like that.
yeah, that you can figure out,
Right.
yes.
But not like the specifics.
No.
Because if you go through the slides, it's all very, like, specific, as far as, like, positioning and.
Yeah, but you would figure out, hey, so the question would be, and the same thing with, what Melissa, we were talking about earlier in terms of, the definition type stuff. It'll be, status post CVA, we're gonna patient status post CVA, who presents with the upper, flexor synergy of the upper extremity. What would be the, optimal position for this patient? Obviously, I would, whatever it would be, I would wanna move them out of that synergy. So it could be like, prone, elbow flexed on their chest, scapula protracted, sideline, elbow, wrist flex, fingers flex, scapula protracted, elbow extended. So there's going to be some component that well, that alone can't be it, so I can eliminate that. So as long as you know the flexor synergy, you can figure things out.
While we're on it, flexor synergy, retraction,
Scapula retraction,
abduction,
external rotation,
external rotation. So even
supination,
supination.
flexion.
But they're not gonna hold it out like this.
No.
What it'll normally look like, it'll still look like this.
It might be like this, but it's more when they put stress through it. So if you ask them to reach for something, that's when it'll come out.
Okay.
Yeah.
Because it won't look abducted,
No.
but,
No, only with stress. So with movement.
okay.
That's when it'll come
So
out.
is that what it is? Like, if they go to reach for something, they'll stay in that?
Yes, they'll go. That's No.
I mean, it could be, but.
It could be, but most likely it's like they could be down the side, and when they reach for something, that's how you
They'll go
see
to
it.
reach and they'll kind of do like
Yes.
this kind of, okay.
All right, any other questions there? Test. 60 questions. It'll be on Moodle.
What percentage of our grade is this?
30. 30.
Do we need,
So, if anybody is having trouble with the Moodle, I'll have hard copies as well. So if you prefer a hard copy, that's fine.
do we need responders?
Good question, I got no idea. Whatever Kevin does.
My problem with my computer,
No, we won't do responding because it's here. So I'll be here.
I tried to.
I'll be the responders guy. When I see you looking around, I'll come by and smack you.
Back to this.
can we spend, I don't know if it, let everyone go.
Yeah, well, we're going to land. No, we're gonna do this in land.
Oh, okay.
If you want to stick around, if you guys, so lab was going to be another, I have some other review questions. If you want to come in, we'll go over that. That was one of the questions we go over. If whoever doesn't, if you guys feel comfortable with where you're at, you can go.
We have to go back down there.
Yeah, that'll be, it'll be. Is, if you're, even if you're oriented by one, are you alert? Yeah, most likely you are, because if you're not alert, there's no orientation. If you're in a coma, there's no orientation. So we always see AO by 3, but you know that alertness and orientation are two separate things.
So orientation, you're more aware. Alert, you're not necessarily aware.
Correct. Alert, you have like, you're alert, you have your lethargy, your obtunded, your stupor, your coma, your vegetative. Those are your different types of alertness, right? So this way I would know, somebody could be alert or obtunded, they need constant stimulus to stay awake. They're probably not going to be oriented, or maybe they're oriented to name.
Were there 5 delineations? There was alert, obtunded,
No, there was alert, there was obtunded, there was stupor,
stupor.
coma, vegetative state, lethargy, and what?
I thought there were 5.
I thought it was like alert, stupor was like.
What's the power?
Stupor, lethargy, alert, lethargic, obtunded, stupor, coma.
Okay.
Five.
So there's 5. Alert.
I don't know, count it. Do they teach you that in Mawa?
What comes first, obtunded or lethargy? So alert,
Lethargy.
lethargy, obtunded,
Stupor.
stupor,
Yeah.
coma.
All right, number 2. Patella absent, patella tendon reflex. Where would you test it? D, L4. 3. Right, there is no reflex for L5, correct?
Correct.
Yes?
Wait, number 4. I thought. What about number 3?
We didn't do number 3 yet.
Oh.
Number 3 is, yes, we did.
Wait, what?
Number 3
3
is
is
B.
B.
Okay, so what's number 4?
We didn't get there yet.
Oh, okay,
Oh, your
okay.
horses.
I'm sorry.
Number 4. C6. C?
C.
C, yep. 5. A. 6. A. A.
6.
Andre, we just talked about this like the whole end of the last half hour.
I did this one when I was in.
Were you before?
And middle would be more lower extremity involvement. Posterior
No, see, so we have
Vision and all that, right?
would
Yeah, they have a hemianopsia, contralateral hemiparalysis, hemiparesis, homonymous hemianopsia,
that's
sensory.
posterior.
That's middle through.
Oh, no, middle, correct, right.
Wait.
C.
6 is A? Yes.
6 is A.
Can we just, can you just quickly, because I know I've looked at it in the slides, but it's good for
Go to
you.
PowerPoint, or you watch your battery?
No, which one you want?
No, go back to PowerPoint, which CBA. And go to the different, go to the anterior. middle street, that's not good. Yeah, so I say, most common site, but, to make you guys study.
Can you go over again what's, like the three doors? Like what the deficits are there?
Yeah, so middle cerebral artery, you have the contralateral hemiparesis. You have contralateral loss, face, upper extremity, and lower extremity.
That's the big difference.
That's the lower extremity, the big difference. The hemianopsia, and then the anterior cerebral artery. Oh wait, contralateral and the loss in the foot and leg. Aha. Made my
That says that for anterior?
Yeah, made my questions crappy.
Oh, no.
Contralateral loss and weakness in face and
Yeah.
upper extremity.
That's
all.
the first CBA.
Yeah, the first CBA one. Oh, you know what? Look to see what posterior cerebral is. That's probably right.
Posterior was like vision and all that. That was the hemianopsia and all that.
Yeah, more vision, dominant, got it. Okay. So that's a crappy question.
Oh man, the one question I got right.
Right. The question on the test, there was a question similar to this on the test, but if you study, if you read the PowerPoint, it'll be more,
It'll be clear.
yeah, a lot more clear. And just because I say, middle cerebral artery is the most common, doesn't mean I won't ask that question.
Okay.
Double negative, doesn't mean. Get that? I said, when I said in class, like the most common site affected is the middle cerebral artery. And I said, because I said that in class, doesn't mean that I won't ask that question.
See, I distinctly remember you saying,
But that
middle
was,
cerebral is never gonna be the correct answer.
that was only to confuse some of the people in the class. But now we have a nicer lamp at this
It's just like the
time.
time you told us that SD wasn't gonna be harassing us this time.
I can only, that I can't control. I can
You
control.
said it,
I know. No, I said, I think,
you said
Most
she's
likely
out
she
of our
was.
hair.
yeah, most likely she doesn't. She was earlier.
So,
But
she's
now that,
sneaking questions into our emails. Just, it was like one. She sent it like one question, it was very random.
I didn't know about that. I didn't know
If you
about
see an
that.
email from her, your heart drops, you're like,
Yeah.
what is this?
All I sang, and then I said, I got your backs.
That I don't doubt.
Thank you. So anyway, to get back to the middle cerebral artery, because I said it in class, does it not mean that I won't put it on
Does
there?
it not mean that?
What did I just say?
Yeah,
Is
then
that a
it'll be
triple
on
negative?
there, it's gonna be on
There
there.
you go. Thank you, Chris.
Gosh,
Thank you.
it's gonna be on there.
I know.
Be ready.
I won't.
MC, yeah,
It's
MC.
triple negative, so that means it.
Try to, it may, probably, potentially.
Yes.
Study those three.
Yeah, so, all right. 7, C, 8, stereodosis, 9, cerebellum, A, right, decreased equilibrium, regular muscle tone, 10, shrugged shoulders, 11, vision, I also put 12, A, 13, shrug, C4, B. Keep it up, Brian, you good?
What was 11?
11 is A. No, B,
B.
occipital lobe.
Okay, all right, got it. Thanks.
12 is
A.
12 is A.
Okay.
Yeah, 13,
B.
B, 14.
D.
So here's the thing, like that, so I think those, like some of those dermatome pictures you see, like, S1, like S1 I've seen coming up the back,
Yeah.
L4, L4 is medial, like L5 is lateral. Almost depends on what picture you would see.
So L5 is right.
So it could be C.
I do L5, yeah, I would say,
But
But I don't know.
L5 like goes to?
I thought it was like.
Yeah, I thought
Yeah.
that L5 was like the middle, or,
Yeah, I thought L5
And then
was like
S-
anterior shin and like the top of your foot, and then S1 was like.
see,
the
and right, but I've seen S1 back,
Yeah, depends what you look at.
right, depends what picture you get.
but it would be more clear.
Oh, absolutely.
You wouldn't have
100%.
that.
I would do that. Nor would the state board do that.
It wouldn't happen two right next to
No,
each other.
no.
Oh, the closest.
No,
would be
they wouldn't do
L4.
that, no.
Okay.
All right, 15.
Wait, so what was it?
Up for
L5?
debate, up for debate.
Oh,
Up for
It could be,
Yeah.
yeah, it could be
Okay.
C or D.
All right, 15,
D.
D.
What was
16.
the question?
See?
I put D, but.
The question was, what's like the dermatome of the
Yeah, okay, yeah, so I just, yeah.
lateral or medial, actually.
16,
So
C.
15, 16, C. 17, what's that called?
Columbus.
Clonus,
Yeah.
right?
Uh-huh.
See?
It's like,
Because with these masks, I hear like, B, C, it's like mumble, that's what I make sure. 18, 19, right, 19 is B, except,
Wait, my goodness.
is what?
I'm sorry, D,
Yeah.
I saw spasticity and expressivity. 20, A, 21, B, 21 is B. 22, yep, C, corticospinal, 23, spinal thalamic, afferent carrying pain, anytime you see thalamus, know it's pain.
So 23 is
A,
the fasciculus gracilis
cuneatus.
and cuneatus. What are they about? It was something about proprioception.
Yeah, proprioception.
But what about it? Like,
Just, I mean,
that's what they're.
yeah, sensory proprioception.
It wasn't one of them like I think cutaneous was T6 and up, and
Yes,
gracilis was
yes,
T7 and up.
correct.
And so those are my notes.
Rubrospinal. What's that
Yeah.
about? The rubrospinal. That's the one I'll get to talk about.
Yeah.
Oh,
Yeah, I'm with you, okay. Right now, I'm just shutting them down
It's
right
like you
now.
said, study the important stuff. If you
Yeah.
don't go crazy with all the little things, if you get that one wrong,
All right, then 24, B, graphesthesia. All right. If you want more, quickness. Okay, which is following characterized by a deep sleep from which a patient cannot be aroused? Stupor, lethargy, coma, obtundation.
Wait, what can you,
Which of the following is characterized by a deep sleep from which the patient cannot be aroused?
oh, that's not. Oh, no.
They cannot be aroused.
Oh,
coma.
Coma. I'll have to look for this. Like, I don't know, I had this in like a folder, and I thought I sent it to you, but I sent you something else. So I'll see if I can find this and then send it to you. Let's see. Which portion of the brain regulates peripheral autonomic nervous system discharges and is responsible for homeostatic mechanisms such as regulation of body temperature?
Hypothalamus.
Hypothalamus.
That was the giveaway at the end.
body temperature?
Yeah, the blood pressure. That's
A
blood pressure.
person with a peripheral nerve injury is most likely to experience which of the following clinical signs? Peripheral nerve injury will experience A, spasticity, B, muscle fasciculation, C, paresis, D, hypertonicity.
Oh, that's the one.
Right, that's right, we had that one.
Yeah, yeah,
Paresis.
yeah.
Right, lower motor neuron, upper versus lower. So lower?
that's true.
God damn you.
That's
guys.
why I was confused, with between the paresis and the fasciculation.
It is muscle fasciculation, right?
Sorry?
It is muscle
Body
fasciculation?
does include.
The answer for lower No, it would be braces, paralysis, muscle up,
It would have to be, a question like most likely or
Yeah.
whatever.
Yeah, it would be that.
Yeah, what's the best answer?
He wouldn't make it that, right?
You wouldn't do us like that.
Yeah. Oh, yeah, so it's my exam.
You get the special exam.
Oh, yeah.
Which of the following questions is most appropriate to determine a person's general cognitive status? Which of the following questions is most appropriate to determine a person's general cognitive status?
You know where you are.
What did you have for breakfast this morning? What season is it today? Which is longer, a yard or 2 feet? Do you remember what my name is? General cognitive status. What did you have for breakfast this morning? What season is it today? Which is longer, a yard or 2 feet? Or D, do you remember what my name is?
C. What's a yard or 2 feet? If you don't know that, you're in trouble.
Well, if you don't know what you had for breakfast in the morning, you're in trouble too.
That's true, I guess.
How about if you don't know the season?
But if you're like in grammar school, like you haven't been taught like measurements, metric system, then you're gonna ask like that. He'll be like, what?
So what's the
That's
difference?
That rationalization is too deep.
Oh, okay.
Yeah, you don't think like
So
that.
what's the difference between a, because I feel like.
Okay, so here we go. A, like what did you have for breakfast this morning? These short-term memory.
That's what I'm memory
Yeah.
saying.
Right. What season is it today? Is orientation. Okay. Which is longer, a yard or 2 feet? That's the computation. That's the cognitive awareness. So that would be the answer. You know what my name is would also be memory.
So it would be safe.
It would be safe. Yes.
Yeah, when you see your general cognitive function, it's like, yard or 2 feet, man, come on. Where are we at here? Where are we at?
The question that I see on one of your exams, there was, the whole time we were talking about something
Yeah, I know,
in,
but the different metrics.
it was like inches, and then
Yeah.
she, on the test.
Oh, I hated
How
that.
many centimeters?
Yeah, and then you had to convert it.
You know, we can convert inches to centimeters?
Yeah,
You
you got that
You
wrong.
got ultrasound or?
No, it was a measurement of something, and I
It might have been like how ultrasound underwater. How far away do you hold it? And the answer was like 2 inches. But then it was like in centimeters or something.
It's going to say a
Yeah.
British patient. You are treating a British patient who is taught the metric system. Here we go. So, in a 10-month-old child with cerebral palsy demonstrating a persistent tonic labyrinthine reflex, which of the following activities will be difficult to perform? Right, why?
Because that reflex is when you're on your back and they bend their head backwards, they go into extension, like their back arches, their legs straight, so, and their arms flex.
Right, that's correct. That's the reason why.
To reach for something, you're gonna go into extension, their arms will go down, they can't reach anymore?
The arms will flex.
Their
Yeah.
legs go into extension, their arms
Yeah.
go into flex.
Yes, when they're supine.
Oh, I'm thinking of,
It's the
I'm thinking of,
opposite.
I'm literally thinking of STNR, yeah.
Then if
So
they,
if your
if,
head flexes, your arms will extend,
Extend.
your knees.
yes.
Isn't that STR?
Yeah, I thought
The,
that was
STNR is the opposite, right?
Well, 18R is this one.
18R is that. The tonic labyrinthine is when you flex, your arms go into flexion, your legs go into extension.
So what's STR?
Guess it's, you know, when you said I thought.
Yeah, I thought.
Yeah, I thought that's what it was. I thought the labyrinth is if you're extended, your whole extremities, both your lower and upper extend.
Mhm.
And when you flex, both of your extremities go.
Where's Lawler?
Oh, no.
This is
Is that on the sheet?
We gotta get to the bottom of this.
That you were talking about?
Yeah, but I didn't look at it. I just went by.
I didn't
lower.
even answer that
I
one.
went, I looked at the lower.
Neither in mine.
That was the one question I was like totally clueless.
I just skipped it.
All right.
Like, I'm not gonna hurt myself.
So, well, this is not trust, but, stiffness,
Not
legs
trustworthy?
straight,
Yeah.
and then, arms bent and elbows and wrists.
So here, ask us something. I didn't get it from here. I got it
right, so, I'm sorry. So in supine, body and extremities are held in extension, and prone, they're held in flexion.
That's the
Prone.
tonic.
So that's
labyrinth.
Oh, see.
Everything flexes with the labyrinth.
When you're prone.
What's your point?
When you're supine, you flex, so you prone to a ball.
This
Supine
says,
is extend, prone is flex.
this just makes it sound like whatever the head does, the rest of the limb does. That's what this says. Reflex should be fully present.
Head goes down, comes folded in, head goes up, comes straight out.
Supine extend. Prone flex.
Well, I got the answer right, but
We wanna know.
How did you get that answer?
because I figured like if the leaves like this, how he wants to extend, so how is he gonna,
Okay,
he's
but,
gonna do
Whether
that, he's
you
doing a
do-
motion that he can't really do.
so, but you're saying that's in, supine.
Yeah,
But what's the head doing when he's doing that?
His head is back.
His head is back. So so his head's
Oh.
extended and his arms are
because
extended?
his head is extended, his extremities are gonna be extended.
And then when you're prone, the head
That's
is,
TLR.
That's
everything is like this.
Yeah, that's what I said that way. That whole extremity. That's what Lawless said. I don't know.
Yeah,
So that's right.
so if you're extending, so the tonic labyrinth, when you're extending, everything's, when your head's extended, everything else is extended.
Everything, okay.
I think with STNR, it's crazy, it's coming back, he's attacking. I think it's just the upper extremities do what the head is doing, and the lower extremities do the opposite. TLR is, they both do what the head is
Right,
doing,
yeah.
you know?
So that sort of sticker on?
So the head,
Just so I know what to remember.
But, so does that still make the answer?
Yes.
STNR is
Yeah, give me like this, you're extending.
Which are all 20 feet. So just the whole.
Right, because you're not able to, even like you're not able to flex your arms up overhead.
Yeah, either
Your
way.
shoulders, right, you're not able to flex.
so Chris.
Lawless.
I know, I would say this.
Common reverse supine is extended posture, shoulder retraction, and elbow flexion. So elbow is flex.
Supine.
That's how I learned it, so,
So-
better the other stuff, but I was looking this up last night, and it did have,
Does it say elbow or
but I had tonic, what does it say for
It says
STNR?
elbow flexion.
elbow? So it could be the elbow, but then the shoulders are still
It says shoulder
extended.
retraction.
Are you talking about tonic?
What does it say for STNR?
Okay, SDNR is upper extremity extension, lower extremity flexion, upper extremity flexion.
What does that have to do though, it depends on the
If the
head.
head extends, the upper extremity extends, the lower extremity flexes. If the head flexes, the upper extremity flexes, the lower extremity extends. So the head and the upper extremity goes together.
Yeah.
The lower does the opposite.
We all agree on this.
That's for
STNR.
STNR.
That's the STNR.
Yeah, everybody believes you, I agree with that.
Okay, we all agree.
Head and upper together.
All right, so,
Okay,
what
now-
was the tonic again?
The tonic,
Tonic is lower and upper.
So you're placing supine, you're flexion there as well.
Flexion of the elbow.
Flexion of the elbow, and that's right.
Extension.
And that's what's not gonna allow you to reach up overhead. When you're supine, you're extended, but your elbows are flexed. When you're prone, you're flexed.
What are the elbows doing?
So what does the lower
I
body
think
do?
you're flexed as well.
So the elbow's flexed and the lower body extends? Or is everything flexed?
Supine?
Yeah, supine.
Supine lower body is extended.
Extends, okay.
That,
Lower body.
Yeah, it's prone for both.
Okay.
Elbows are prone for both. Or the lowest.
So what's
Yeah.
the difference, just prone or supine?
The difference is, when you're prone, your hips are also flexed. And when you're supine, your lower extremity is extended, your elbows are flexed,
So the only difference is the lower extremity.
pretty much.
So prone,
Everything's gonna flex,
extend.
supine, you're gonna go extension,
Well, also
elbows
your
are.
posture. Supine, you're in extension posture,
Yeah.
prone, you're in flexion.
prone, are you
But-
protracting?
Protract.
Yes,
Yeah.
yes,
Supine, you're retracting.
retracted,
So
yes.
that's,
But I think the thing is that for that question, the tonic labyrinthine, when you're supine, you can't reach overhead.
Because you're
your
retracted.
elbows are flat, yes.
Yeah, okay. So, yeah, the elbows stay the same, but it is, everything is going to that extensor synergy when your head extends. It's just the elbows stay the same. Yeah. All right, I dig it, I dig it.
So can you say that's not, remember the reflexes? No. Unfortunately, because, you know, they reemerge.
Well, we're focusing on the ones that come up the most often, right?
The STNR, ATNR, tonic labyrinthine, when we talk about the plantar and palmar, when we get into TBI, you're gonna see that again. Those are 5, you know, the star reflex, you know, with the Morrow, you know,
Yeah,
the rooting, right, you know, Landau, you're not gonna see that.
they go away.
Just those
There's like half a dozen, yeah.
Yeah, STNR, ATNR, tonic labyrinthine are the bigger ones that you're gonna see. Plantar grasping, yeah. So we don't, that's why, like, we never lose those reflexes. We just sort of, they subdue, right, they subside. Yeah, so when you yawn, yeah.
But the younger generation brought it back because they're always like this. So like now it's in the forefront of their mind.
Now they're dabbing all the time.
Yeah, so it's just,
But that's not it though.
that's not the reflex?
No, we gotta,
This, right,
Oh,
you can't.
Okay. They tried.
it's like you got the bow and arrow, you know?
Okay.
No.
Yeah.
I have a question for
Yes.
your anatomy lecture, you said, when you're talking about like subarachnoid and urinary.
Oh, yeah.
What?
That will be on there, but go ahead. That will be on there, but go ahead.
Oh, okay, never mind.
Never mind. I don't care for my own
Fair
personal.
enough. Nothing's on there about that. Yeah.
The,
Just read the question. Take your time and read the questions.
You said where's it coming out of the hemorrhage? Like, I need to know the answer.
What's that?
Where's the most common area?
Subdural. Yeah, subdural hematoma.
most common,
I just know because I looked it up.
Like, what area do you give, like, epidural stitch?
For what? For what?
For
Most
your
common.
anatomy, like the first part.
most common for what?
Subdural hematoma.
Oh, a
Where you
hematoma.
would see a hematoma. Right. And so the bleeding on there, you know, obviously your skull is fixed, it's going to go inward and put pressure on the brain.
I've looked at it a couple times, 2-3 times or whatever, but can we quickly review the rhythmic initiation, agonist contraction, agonist reversal, because there's like 7 or 8 of them,
Yeah.
just like to get our terms down. So,
What are you thinking of it?
agonist reversal, what's going on?
It's when you're pushing and the patient's resisting, they're trying to, they're in quadruped and they're pushing up.
Concentric
alright.
followed by
Yeah.
eccentric.
So, for example, it would have, if I was pushing here and I went concentric, eccentric.
So I'm like, I bend the arm up, okay, down slow, fight, agonist reversal.
Agonist reversal.
Rhythmic initiation. I got you, relax. That's what we're supposed to do, let's do it together.
Passive, then.
Active assisted, not do it your own, then active.
And then maybe there's some resistance.
Right.
That is
Rhythmic initiation.
rhythmic initiation.
Right. Alternating isometrics. Hold here, hold. Alternating isometrics. Hold here, hold. Rhythmic stabilization.
Oh.
Rhythmic stabilization, it's like
It's
rhythmic progression.
progression for rhythmic initiation.
Initiation, okay.
Resisted progression, go walk.
This is just for gait.
Yeah, just for gait.
progression.
But it can be any component of gait. Repeated contractions is that stretch throughout.
A quick stretch.
Yeah.
Could you show what would
Yeah.
that?
All right, so let's do D1. Bring it up. So that stretch, you got to provide that twitch.
Yeah.
That's, yeah, it's gonna help initiate that
That's
twitch.
repeated contractions.
Repeated
When might you want to
contractions.
use that with an actual?
You want to use it if you're looking to increase strength, if you're looking to increase the muscle to fire throughout the whole range, you can do that.
Rhythmic contractions.
Yeah.
And then there was,
For that gate, the gate one is
Resisted progression, yeah.
Resisted progression. Then we had,
Alternating, oh no, you
Let me
didn't.
do that.
what's the one where you have co-contraction? Maybe that was rhythm.
That was like probably the rhythmic initiation.
Yeah.
No, sorry. Alternating isometrics.
Alternating isometrics. No, but then rhythmic stabilization, is that co-contraction?
Could be, yeah.
Kind of.
Yeah, yeah.
Because they're just kind of like trying to brace themselves in all things. There were a couple more. Hold, relax, contract, relax. They're basically the same thing.
Yeah. Well,
One's,
yeah.
one's isometric, the other one's
Correct.
concentric.
Which one's which?
Hold, relax is isometric.
Uh-huh.
And
And then
then
there's hold, relax, agonist, contraction.
hold, relax, agonist contraction. That's basically, so if you had, you're doing a hamstring, you'd have the antagonist, the hamstring, and then you would back off and let them
Yeah.
do their hip flexors.
When applying the hold, relax technique, when applying a hold, relax technique to a person lacking knee flexion, what should you instruct them to do? So when applying the hold, relax technique to a person lacking knee flexion, what should you instruct them to do? A, contract their quads, then contract their hamstring. B, contract their quad, then relax the quad. C, contract their hamstring, then contract their quad. D, contract their hamstring, then relax their hamstring.
B.
For hold, relax.
Hold, relax.
A, contract their quads, then contract the hamstring. B, contract their quad, then relax the quad. C, contract the hamstring, then contract their quad. D, contract their hamstring, then relax your hamstring.
I would say D.
B.
B? What was B?
B is ready. I want to increase knee flexion. All right, hold it here. Hold. Hold. Good, relax here. That's B, that's hold, relax.
Hold.
A is like hold, relax, agonist contraction.
So wait, but isn't that agonist contraction?
Ready?
No,
Your heart set.
no, because you
I'll explain to you why it's not. If you
just include,
you're not gonna do
Relax
this.
your flexion. So A,
because he didn't.
kick into my hand, kick, no, kick into my hand, sorry, kick. All right, so that's hold, relax, kick. Bend your knee, that's A. That's hold, relax, agonist contraction. Just hold, relax, kick up, kick into my hand, kick hard. Good, and relax. And then we stretch, that's hold, relax. That's the increase in knee flexion, yeah. Because everything else was pull back. If I'm resisting here, what am I looking to inhibit? Hamstring. So if I do this, what direction am I looking to increase? I'm firing, fire, I want these to inhibit, then I'm looking to increase the extension with the hamstring. Okay?
I mean, I'm still confused about A and B.
Can do
Sit.
I need to see it,
Hey.
So agonist contraction.
And kick up. Hold, relax, kick.
Okay.
Pull, bend the knee, pull. Agonist contract.
Okay, that makes sense.
That's it.
That's it.
This is just hold, relax, kick the leg up, kick. Good, relax, and I'm stretching the new range. That's hold, relax.
So the first one, you allow me to move this
No,
way?
I'm still holding you, kick.
Okay, agonist contraction. That's contracting. That's agonist.
No. This is just hold, relax.
Okay. Why is that? I'm sorry.
You're kicking.
Okay,
Right?
and you're holding.
Kick.
Yeah.
And you're holding this
Huh.
isometrically.
Okay. And then I relax.
Relax.
And then you bring me here.
Yeah.
But then,
Then you're contracting the hamstring to inhibit the quad. You get more knee flexion. We're looking to get knee flexion.
oh, so agonist contraction,
It's
expect.
after the fact.
So do the
Hold, relax.
So agonist.
Hold, relax first.
Okay.
Kick. Agonist contraction, pull back.
Oh, so you don't do anything for agonist?
No.
Oh,
So
okay.
you do it.
Gotcha.
And
Oh, man.
No,
Yeah.
I want them to act.
Oh,
Yeah, 17.
yeah. If it was a hamstring, I would have gone. But knee flexion is like
Yeah,
reversing in my mind.
right, that's right, yes.
Yeah.
so one of the things that
The
could.
right answer, no, is kick. Yeah. Contractor. You're speaking.
Yeah, okay, that's fine.
I'm just
What was
explaining,
the question?
I'm just defining what the others don't work.
Oh, okay.
One of the things that confused me about that was
why I think when you see knee flexion, you're thinking hamstring right away.
Yeah.
But knee flexion is restricted because of quads. Yeah, and that would be the case.
Alright.
But you can actually inhibit them both ways,
You
right?
can inhibit them both ways, of course, but again, sit there and do it. That's really the whole key. Right? Makes sense? What's that? How do you hit both? You're not going to because you're looking, you're gonna confuse it. But I can, if I wanna increase the extension, go back. Well, let's get the hamstring to stop working, and then,
And that's
Relax.
hold and relax.
that was a whole relax, correct?
Okay. And then now.
Contract, relax, pull, good, relax, so contract is the actual time.
And then agonist reversal.
And now this is the increased extension,
Yep.
pull down, bend the knee, bend, good, pick up as much as you can, pick up hard,
And she
in
did-
the range, yeah.
Okay.
So right now I'm new range is here, pull, good, pick up, pull, pick up.
Got it. Okay.
And you keep going until, right, to whatever you can get.
So patient does.
Yes.
You can promote, you can inhibit using the agonist or the antagonist,
Correct.
depending on who you're working with and
Yeah.
what they
Well, yeah,
what they respond to.
what you find is better for you. Different techniques.
That one took a while.
Good.
Yeah.
Any questions, email. All right, send me an email.
Good. Vertebro baciller, that is mostly associated with,
So just pass that along to your CIs, that they should send an email directly to my email address. Don't reply to that email that they receive. It's a common mistake, all right? So just pass that along if you could, please. All right, so, we finished the shoulder, we're now moving down the upper extremity, and we're looking at the elbow and forearm complex. And again, just like we talked about with the shoulder, there is no elbow joint, right? So we don't want to be sloppy and refer to the elbow joint. There's an elbow and forearm complex. And that complex really is comprised of 3 joints, surrounded by one common joint capsule, which is extremely important to recognize because obviously if there are any issues, any restrictions within that joint capsule, it's going to affect 3 separate synovial joints. All right? And if you're getting a login, I see Chris has got that screen coming up, you can just ignore that. It'll just say proceed to Essex website or something. Go directly to Essex EDU. And then the browser will open in, the Essex webpage will open. All right. So again, we've got 3 synovial joints within this one common joint capsule. And the proximal radioulnar joint is actually considered part of the forearm, even though it's located within that capsule. So again, we've got 2 separate areas that are represented in one of those joints partially within one joint capsule. So again, kind of a complex, okay? And the elbow serves as that middle link in that upper extremity chain. Remember we said the main function of the shoulder complex is to position the hand in space for function, for upper extremity function. Grasping, reaching, holding, etc. And this elbow serves as elbow forearm complex serves as that middle link in that upper extremity chain. Okay. We move to the next slide, if you will advance for me. Well, that's great. I'll give you that. All right. So there's 2 degrees of freedom in the elbow forearm complex. And again, just as we said in the shoulder complex, that complex is designed primarily for what? More mobility or stability? Mobility. And again, remember the rule of thumb, you sacrifice stability for mobility and vice versa. So the elbow forearm complex attempts to kind of provide some mobility and some stability. And of those 3 synovial joints, one is extremely stable, the others are not. okay? But, again, it allows for positioning of the hand, positioning of the upper extremity for function, all right? It attempts to balance that mobility and stability. And when we look at some of the disorders that we might see in the elbow forearm complex, particularly the humero-ulnar joint, we'll see that that loss of stability can be extremely disabling, all right? And just like other joints, there can be a number of injuries that these joints can be subjected to, and we'll look at some of those, all right? But it tends to be certainly more stable than the gunnicular joint, not as stable as your AC or SC joints, but certainly more stable than the gunnicular joint. Right? But it does provide a fair amount of mobility as well. If we look at the humerus, the humeral component of that elbow forearm complex, we have medial and lateral epicondyles on the humerus. We have a lateral supracondylar ridge. We have a trochlea on the medial aspect of the humerus and a capitulum on the lateral aspect. There are two main grooves at the distal portion of the humerus, the capitulotrochlear and the trochlear groove. Okay? We have three important fossae, or fossa singular, the coronoid, radial, and olecranon fossa. Fossae. Which again, you're going to be identifying all these structures and all these bony landmarks as part of your first lab today. So here's just our illustration. We're focusing on the distal humerus, just as we focused on the proximal humerus when we looked at the shoulder complex. Okay? So we're just outlining these different structures that you certainly want to become familiar with, particularly for your bone fracture. Okay? And for those who just came in, you're just going to log in. You can either log into your own device, go to your Moodle room, or you can use these PCs. All right? And you go to your Moodle room, we're opening lecture 11 and 12, that PowerPoint. I have to advance them here. I can't project them, so you're just going to have to follow along as I go to the next slide. Okay? And our next slide, we're looking at bones. Now we're looking at the ulna, the ulnar component of the elbow forearm complex. There are two prominent processes, the olecranon and coronoid processes. There are two notches, one particular notch, the trochlear or semilunar notch, interchangeable term, okay? The trochlear ridge, the ulnar tuberosity, and the radial notch. All right, so these are the significant structures that you'll be identifying on your ulnae, plural. Okay. If we look at the radius, we have a radial head, which is basically circular, a radial neck, a radial tuberosity, and a fovea. And that fovea is going to be an important structure that, as we look at the humero-radial joint in a minute. Okay. And again, this is just the next slide. You're looking at the illustration of these structures on our radius. Okay. Radius and ulna. You've got both ones illustrated here. All right. So be familiar. One thing that's very important is what's one of the things that you notice on these illustrations, and we look at bony landmarks, a name that's common to both the radius on the ulna. Just look at it. A bony landmark that is common to both bones.
Styloid process?
Styloid process. So if you're asked to identify a structure and you tell me styloid process, you're going to get half credit. Yes, it's a styloid process, but on what bone? You certainly have to be able to distinguish your radius from your ulna. Easy enough to identify the bones, but don't forget, and remember, as I said to you before, you can't go wrong being too specific. Okay? And that's particularly important when you start talking about things like a styloid process. You have more than one. Okay? So please make sure that you take note of that. So if we look at the proximal joints of, next slide, we'll look at the joints, we'll look at the proximal aspect of this elbow forearm complex. We have a humeral-ulnar joint. The primary, quote, elbow joint is that humeral ulnar joint, okay? The stability of that joint is significant because of the morphology of the bones, morphology of the joint. So the bony geometry provides a tremendous amount of stability because of that concave trochlea on the ulna and that concave trochlear notch on the distal humerus. So you've got a lot of bony congruency at this joint. There's also a very strong joint capsule that provides a tremendous amount of ligamentous support. So that's where we get the majority of our stability in the elbow forearm complex, is the bony geometry is primarily responsible for that stability. Okay? The ligamentous support just adds to the stability of the humeral ulnar joint. Okay? It has a loose but strong joint capsule. There's a lot of ligamentous tissue, but it's not tightly bound. It's not tightly adhered to either the humerus or the ulna or radius. So it allows a fair amount of motion. Okay? Again, the primary stability is due to bony geometry. So you've got to think of a very think of it like a leather pouch, right? Very strong, but it's not tightly adhered or tightly surrounding the humerus and the ulna. And there's a very large bursa that's present here over the olecranon. Okay. I don't know if anybody has heard. There's a lot of. Again, I know that I think Dr. Stutz-Doyle calls them trash can terms. I've heard garbage pail means the same thing, right? Has anybody heard of a common term that's used to describe a bursitis of the olecranon bursa? Any of you that have been in sports, athletic training, or wrestler's elbow? You may hear that term, wrestler's elbow. You may hear it referenced in your clinics if they treat athletes, especially wrestlers. Why do you think that would be? Why would it be wrestler's elbow when we're talking about an olecranon bursitis? Any ideas?
A lot of impact from the mat, from hitting the mat.
Impact, and it is very common for wrestlers to be in a quadruped position, right? On knees and elbows, right? So they may be in this position. Okay, that's the starting position for most wrestling matches. Okay, so there's a lot of compression and shear on that elbow, and particularly over the olecranon bursa. So you may see it referred to as wrestler's elbow. Again, we've got tennis elbow. We're going to look at golfer's elbow, right? Tennis leg. Has anybody ever heard the term tennis leg? No? You will. Okay. Well, we need to be more specific, right? That's a garbage pail term. Wrestler's elbow. Okay. Well, that's a wrestler who hurt their elbow. It doesn't tell me very much. But it's generally associated with an olecranon bursitis. Okay. If we look at the osteokinematics of the humeral ulnar and the humeral radial joint, okay, the humeral ulnar joint is primarily a hinge joint, 1 degree of freedom. Again, remember, it's got a very strong bony geometry, a lot of bony congruency, and it really just allows that joint, only allows flexion and extension in the sagittal plane along the medial lateral axis. Okay, again, make sure we're referring back to your anatomical position. The trochlea of the humerus is more distal than the capitulum. Okay? Which means when we look at our humerus, you will look at them and see the humerus, that is an oblique joint angle. Because that trochlea is placed more distally than the capitulum. So because of that, and you can see that on your illustrations, okay, that's what is responsible for that carrying angle that we see. Right? You've all heard the term carrying angle, right? Okay. So it's not a perfectly perpendicular joint. It is at an oblique angle. okay? And that's creating that carrying angle that we see at the humeral ulnar joint. The distal humerus is rotated slightly anteriorly, distally, and the proximal humerus is rotated slightly posteriorly. So if we look at, again, proximal humerus and distal, you look down the shaft of that humerus, you're going to see they're rotated in opposite directions. Okay, one, we want to place the humeral head in the glenoid. So we've got that posterior rotation proximally. Distally, as we go down the shaft of the humerus, it tends to now rotate more anteriorly. Okay, that's again to create more mobility, distal to proximal, proximal to distal.
Professor?
Yes.
So is this something to do with like whole closed chain and open chain? Does
No,
this
we're just-
rotation change?
Here we're just talking about the anatomy of the bones. Okay, that's not going to change. You know, your anatomy is not going to change. How the joints are moving, certainly. As we do something in an open or closed chain, yes, we're going to change what's moving on what. The anatomy is never going to change. So we're just looking at the static bone, the bony anatomy of the humerus. Okay, the morphology, bony shape. Okay. So again, here's just another illustration, looking to see how the trochlea is placed a little more distally than the capitulum. We're creating that carrying angle, okay? And that trochlea is on the medial aspect of the humerus, capitulum on the lateral aspect. Again, that's what's going to give us that common carrying angle. All right? So again, just a little illustration of our bony morphology. If we look at the osteokinematics of the humeral ulnar and humeral radial joint, total range of motion is from about 0 to 145 degrees of flexion. If we look at the end feel in extension, it's bony because of that olecranon of the ulna contacting the olecranon fossa of the humerus. Okay. Flexion is usually a soft end feel because you're approximating the forearm with the biceps. Okay. The more muscular tissue someone has, certainly is going to impact on how much flexion they will have, but it's due to that soft tissue approximation. It's not because of a limitation within the joint. Right. And if any of you have had any very muscular patients, you need to know that, well, their range of motion is going to be different than someone who's not quite as muscular, or anyone who's more slender, doesn't have as much muscle tissue. Right? But we got to differentiate that end field. All right. If we look at the arthrokinematics of humeral ulnar and humeral radial joint, the associated motions, remember we talked about anatomical and associated motions. At the humeral ulnar joint, there's not a whole lot of associated motions. There's anatomical or physiological motion. Okay, we've got that flexion extension motion. But to try to get a lot of accessory or associated motions at that joint, it's very limited. What does that mean to us? If the amount of accessory motion of the humeral ulnar joint is very small, what does that mean to us clinically? What would that indicate to us clinically? What would it be difficult for us to do?
Anything outside of that range of motion. So for instance, if you can't flex or extend anything, like abduction will cause injury.
It'd be very difficult to mobilize that joint.
Oh.
Right? There's not a lot of accessory or associated motions at that joint. Okay. You're still going to mobilize, but it's really going to be more stretch into flexion or extension. You're really stretching more soft tissue, as opposed to the humeroradial joint that is very easily mobilized. Okay? There's not a lot of bony approximation. There's not a lot of bony congruency between the humerus and the radius. Likewise, there's not a lot of bony congruency between the radius and the ulna. Pretty easy to mobilize that joint. Not easy to mobilize the humeral ulnar joint. Yeah, Chris.
Flex your elbow, you have more congruency between the head of the radius and the.
As as you flex the elbow, yes, now you're starting to approximate that radial head with the radial fossa of the humerus. Yeah, that's when you get more bony congruency. That's why we see the closed pack position for the humeral-radial joint, okay, the closed pack position. Remember, now we're talking about where there's the maximum bony congruence, balance between bony congruency and ligamentous tightness is actually about mid-flexion, mid-pronation for the humeral-radial joint, okay? So if you go into full flexion, yes, you're going to get more approximation of that radius to the humerus, but now you get a little more laxity in the ligaments around that joint. That's why it would not be the closed pack position for that joint. Okay? Humeral ulnar joint, full extension, right? Now you've got the entire trochlea congruent, approximated with the trochlear groove of the humerus. Okay? At the radial ulnar joint, it's that closed pack position is either going to be full supination or full pronation. It's a very unusual situation in that you have two closed pack positions for that particular joint. So if we wanted to mobilize, if we're going to attempt to mobilize the humeral ulnar joint, we're going to have to do it in flexion. We already know there's not a lot of accessory motion there. There shouldn't be, because that needs to be a very stable joint. Okay? That being said, about the only time we're ever going to even look to mobilize that joint is when there really is some pathological restriction of that joint. Otherwise, we're creating an instability where there needs to be a lot of stability. Okay? And when we look at the pathologies of these joints later on, we're going to see what happens when we don't have stability of that joint. Okay? It's intended to be very stable. Unlike if we're looking to mobilize the craniohumeral joint, well, we need a lot of mobility there, right? So we're going to focus a lot of our attention on accessory motions of the craniohumeral joint. You're not going to spend a whole lot of time on accessory motions of the humeral ulnar joint, even when there's a limitation of motion. It's mostly going to be stretching of soft tissue. It's not going to be joint mobilization. Okay? So again, when we talk about radial ulnar joint, we're talking about the proximal radial ulnar joint here, with the elbow forearm complex. When we move on to the wrist and hand, we'll be looking more at the distal radial ulnar joint. So proximal radial ulnar joint, closed pack is either full pronation or full supination. So if we want to mobilize that joint, we're going to be anywhere between pronation and supination. Any of those degrees of motion, any position of the joint is going to be amenable to being to mobilization. Okay? Because every other position is a loose pack position. Again, if we look at the resting position of these joints, okay, that's the position of comfort that somebody is going to assume when there's any pathology, injury, or pain in these joints. Humeral ulnar joint is about 70 degrees of flexion, about 10 degrees of supination. That's going to be our resting position. Humeral radial joint is going to be full extension and full supination, okay, of the humeral radial joint. Okay, remember, we've got a complex here, so you're not going to isolate, the motion of just the humeral radial joint. It's part of a complex. And the resting position for the radial ulnar joint is about 70 degrees of flexion and 35 degrees of supination. Okay. Again, if we look at that orthokinematics, we've already mentioned that at this humeral ulnar joint, you've got a concave ulnar trochlear notch and a concave humeral trochlea. All right? So you've got a concave on convex, concave moving on convex, centered open chain. Right? In flexion, as we flex, the coronoid process of the ulna abuts, contacts the coronoid fossa on the humerus. So to get into full flexion, those two bony structures abut one another, contact one another, come in maximum contact. But in order for that to happen, We already said we have a relatively loose joint capsule here, right? It's very strong, but it's very loose. It's not tightly adhered to any structure on the humerus or radius or ulna. And if we don't have sufficient length of that posterior capsule, it's got to lengthen, it's got to stretch as we go into flexion. And if there's not sufficient laxity of the posterior fibers of the medial collateral ligament and ability to elongate the ulnar nerve, and we've got sufficient length of our elbow extensors, we're not going to be able to get into full flexion of the humeral ulnar joint. All right, so you've got other structures here that need sufficient length. And if you've got a limitation of any of these structures, you're going to have a limitation of flexion. All right? So we would always need to determine if somebody's got limited elbow flexion, we've got to determine, well, which structure is it that's interfering with that range? Okay? It could be the length of the elbow extensors. It could be an adherence of the ulnar nerve. We may have to do some nerve gliding. Okay? So there are multiple structures that could limit that elbow flexion. In addition to just joint contracture that may result from immobilization. So that's going to involve more of the joint capsule, the ligamentous tissue becoming adapted to a short position. Okay. Okay, again, now we've got a concave ulnar trochlea notch moving on a convex humeral trochlea. In extension, that olecranon abuts the olecranon fossa, so in the opposite direction. Okay? And just like we need sufficient laxity in the posterior capsule to get full flexion, you've got to have sufficient length or normal laxity of the anterior capsule and the anterior fibers of the medial collateral ligament, and sufficient length in the elbow flexors to get full extension. So again, we'd have to make a determination if someone's not able to get into full extension at the elbow, where's the problem primarily arising from? Is it muscular? Is it ligamentous? Okay. So if we've got any injury to the medial collateral ligament of the elbow, we're likely to see some limited motion, either in flexion or extension, or both. Right? Because that medial collateral plays a great role in determining whether full flexion and full extension is present in the humeral ulnar joint. Okay, if we look at the humeral radial joint arthropythomatics, you've got a concave radial head, proximal radius, on a convex capitulum on the humerus. In full extension of the elbow forearm complex, there is no articulation, no contact between the radius and the humerus. The radius just is hanging in space, if you will. There's no bony contact at all. As we flex, now that radial head slides into the capitulotrochlear groove. Okay? So that is not a very stable joint at all, but certainly provides a tremendous amount of mobility. Okay? There's virtually no bony approximation at the radio-humeral joint or humeral-radial joint until we start getting into flexion. All right. Now we've already made reference to the carrying angle, which might also be called the cubital angle, right? What is this region referred to as? No, you used the term before. Okay.
Just cubital.
If this is cubital angle or cubital valgus is the angle that's described, cubital fossa, right? This would be antecubital. Okay.
Oh boy.
So cubital is on the anterior aspect of the elbow, antecubital on the posterior. Okay. Again, just in case you see reference to these areas, this is the cubital angle, also the cubital angle, also cubital valgus, right? On average, it's about a 15-degree angle in females. On average, it's about 15-degree angle in the entire population. Tends to be greater in females than in males, okay? It used to be that the prevailing thought was the reason for that is that anatomically, women, females tend to have wider pelvises, and as a result, in order to clear the pelvis when the elbows are in extension, females had a greater carrying angle. Well, that's been kind of poo-poo. Why is there greater carrying angle in females and males? We really don't know. It just is, okay? It's really been disproven that that's a significant factor in determining carrying angles in females versus males. It's just generally speaking, you're going to see carrying angles in females of anywhere 17, maybe 18 degrees. Not uncommon in males that it'd be less than that. But likewise, you can have a lower carrying angle in females and a higher carrying angle in males. Okay, it's just something that we see anatomically. Greater angle in females and males. Okay. If we see a cubital varus, where now that angle is in the opposite direction, okay, we're not in valgus, we're actually in varus, that is generally the result of some type of fracture, and usually in the distal humerus. And that's what this next illustration is of. Okay, if we look at the normal carrying angle, you can see an excessive cubital valgus. Okay, in this case, it's about 30 degrees. You could also see a cubital varus, okay, which could simply be congenital. Doesn't mean that there's been a fracture of the distal humerus. But you could also see a gunstock deformity. What that means is this picture on your next slide is meant to illustrate it a little bit better, okay? You can see that obvious deformity of the right upper extremity. That was the result of a distal humeral fracture. They call it gunstock because the shape of the gunstock on a rifle, okay? You may be, I don't want to call it privileged, it's not really a privilege. You may see some very interesting deformities in your patients, in your career. It's not uncommon for people who may have grown up in foreign countries where the medical care may not be quite as good to have untreated fractures or fractures that heal spontaneously and abnormally. So you'll see some very unusual deformities. I'll tell you a couple that I've seen in my career. When we get to the knee, we'll jump ahead a little bit. Everybody's heard of patella alta and patella baja? Yes? What is patella alta? It's more superior, and patella baja just the opposite. The patella is situated more distally than it should be. Okay. I once saw a patient with a patella baja, okay, where his patella was here. Here. That was patella alta. Okay, his patella was here. At the distal quad. Okay, what do you think happened? How did that happen? Patella tendon rupture, yeah. And it was never treated. Okay? It was untreated. That's something that would have to be surgically repaired. Okay? This is years later. It's way too late to surgically repair this. Okay?
That was an alta.
That was an alta, yeah. So you can imagine how good his extension was at the knee, right? He had no extension. He's completely lost the mechanical advantage of the anatomical pulley called the patella. Right? So his extension was virtually not.
It's just like in the muscle, it's like.
Yeah, yeah. His patella tendon had ruptured and it had scarred down. But it was now, his patella tendon, where it should be maybe this long, was about that long. So that's a deformity that you could see. I also had a patient one time who had 30 degrees, actually I think it was about 35 degrees of elbow hyperextension. man likewise had fractured his distal humerus. It had healed, malunion, right? Didn't heal properly. So now the bony geometry was severely altered. And he had 35 degrees of elbow hyperextension. Do you think his flexion was normal? No. He's going to lose about 35, 40 degrees of elbow flexion. Because his entire range has now shifted into extension. And that was, again, the result of an untreated elbow distal humeral fracture. Okay.
I actually have an untreated fracture of elbow too. I don't know why.
You got hyperextension on the left. See that? Yeah. Yeah. How old were you when that happened?
Maybe 8 or 9.
8 or 9?
I was in a third world country where insurance is no good.
Right.
So
Right.
that's it. So.
What? Not that bad. You're lucky.
Yeah, I know.
It's not that bad. But yeah, again, you can see some, what we might assume is hypermobility. Well, no, it's not really hypermobility. It's just an abnormal
Yeah.
bony geometry due to a fracture that did not heal properly. Often that's the reason. Okay. Again, when we look at this carrying angle and how it changes, that carrying angle, we see some lateral rotation at the glenohumeral joint, with elbow extension and forearm supination in order to visualize that carrying angle. Okay? And again, we don't know why this is the case. We go into the anatomical position. We're in lateral rotation of the glenohumeral joint, lateral rotation of the humerus, and elbow extension and forearm supination in order for us to visualize that carrying angle. If you look at me, you can already tell I don't have a very large carrying angle. Not large at all. Okay, what, maybe 5 degrees? Again, one thing that we have to keep in mind, as we flex, that carrying angle decreases. How come? Why does that angle decrease as we flex the elbow? As we flex the humeral ulnar joint. Why is the angle present? Why is it there anatomically?
Because of the oblique angle of the capitulum
Exactly.
and the,
Right, because of the oblique angle at that humeral ulnar joint. So as I flex, I'm actually moving medially. I'm bringing the distal forearm closer to midline as I flex. It moves away from midline as I extend. It moves toward midline as I flex, simply because of the bony geometry. Okay? And one of the things that's proposed is, well, that's so that we can bring food to our mouths more easily, right? Without adducting the upper extremity. Okay? We can simply bring food to our mouths by flexing the elbow. It's a theory. Okay? Again, we don't know why this carrying angle is present. But it's one of the theories that as we've developed and evolved, why that carrying angle is useful functionally. So that we can bring the hand to the mouth more easily. Okay? So we've looked a lot at the bony geometry. Let's look more at the soft tissue of the humeral, ulnar, and radial articulations. Okay? We've already said there's a very prominent joint capsule, relatively loose around the 3 joints of the elbow-forearm complex. We've already mentioned that that joint capsule becomes taut in extension, and the posterior aspect becomes taut in flexion. Okay, anterior capsule has to have sufficient laxity to get full extension. Posterior capsule has to have sufficient laxity to attain full flexion. Okay. The medial collateral ligament really consists of 3 parts: anterior, posterior, and transverse fibers. We've already said that in order to get full flexion, the posterior fibers have to have sufficient laxity. In order to get full extension, those anterior fibers in that MCL has to have sufficient laxity. So we can really break down that MCL into three portions: anterior, posterior, and transverse portions. Okay? So functionally, it's important. What's another term, if any of you are fans of baseball, what's another term that you'll hear used to describe the MCL, medial collateral ligament of the elbow? The ulnar collateral ligament, synonymous. Okay, the ulnar collateral ligament. Okay, so you may see it referred to as a UCL, you may see it referred to as an MCL. From a purely anatomical standpoint, we call it the MCL. Okay. The lateral collateral ligament, one second, Chris. The lateral collateral ligament is really more of a rope-like structure. It doesn't have specific portions associated like we see in the MCL. It's not as broad, it's not as flattened, it's more of a rope-like structure. Very unusual to see any rupture in the lateral collateral ligament. Not at all uncommon to see partial or complete ruptures of the MCL, of the medial collateral. Okay, because it's a flatter structure, and again, that rope-like structure of the LCL makes it a little bit more resistant to tear. Yeah, Chris?
I'm saying medial collateral ligament of the elbow or of the knee, like when you're documenting or...
Yeah, you would say medial collateral ligament of the elbow. If you just say MCL, of what, right? Now, if you say UCL, well, it's ulnar collateral. I know you're not referring to the name. But, you know, from an anatomical standpoint, you would call it the MCL of the elbow. Okay? Just so we know what we're referring to. Okay? So an important distinction between that medial collateral and lateral collateral of the elbow. Okay? The other soft tissue that we need to be aware of around the elbow joint, there are a lot. There actually are 7 throughout the entire elbow complex. 3 of those bursae are associated with the triceps. The largest is that olecranon bursa that I've already referred to. Okay, just like lots of bursae, part of its function is cushioning, absorbing force, and also reducing friction of muscle and tendon tissue moving over bony prominences. But particularly that olecranon is to absorb force. Okay? I had some swelling of my olecranon bursa on Monday because I banged my elbow into a door. And I had some swelling in the olecranon bursa, which has gone down at this point. Okay? If we look at the articulations between the radius and the ulna, we've got both proximal and distal radial ulnar joints, so we've got to be specific, right? You don't want to ever just say radial ulnar joint, because there are 2. Okay, one associated with the elbow forearm complex and one associated with the wrist and hand. And right now we're really looking more at the proximal radial ulnar joint. Okay, there's 1 degree of freedom. The primary movement that we see at that proximal radial ulnar joint is what? What kind of motion do we see there? Think about our definitions, right? Roll, glide, spin. Spin, right? It's really spin. You look at the long axis of that radius, it's really, we're spinning on that long axis. Okay? That motion is occurring in the transverse plane. Again, remember, we are in the anatomical position. And in an open kinematic chain, that radius is pivoting around the ulna. Bless you. The radius is pivoting around the ulna. It's spinning. It's really a spin within that, well, we're going to talk about the ligaments in a second. It's spinning in that, in relation to the ulna. Okay. The combined range of motion of both the proximal and distal radial ulnar joint is about 150 to 180 degrees. Is it possible to have movement at the proximal radial ulnar joint without having movement at the distal radial joint? Distal radial ulnar joint. Is that possible?
No.
Functionally, physiologically, right, anatomically. Can we have motion at one joint without having motion at the other? It's an easy question if you stop and think about it for a second.
No.
Can you just have movement, motion at the proximal radial ulnar joint? Anatomically, not motion that we're creating. No, you can't. It's impossible, right? If I mobilize that joint, I'm applying a force, an external force. Yeah, I can cause movement between those bones without having movement at the distal radial ulnar joint. But physiologically, no, it's impossible. If one moves, the other's going to move. Yeah.
So when you're saying the spin is occurring, is that between the head of the radius and the capitulum? Or during pronation?
The radial fossa of the humerus, of the ulna, excuse me.
That's
We're only going to contact the capitulum when we flex the elbow forearm. So when we're looking at that pronation supination, at the proximal radial ulnar joint, that movement is occurring between the radius and the ulna, not between the radius and the humerus.
And when we're talking about spin, it's because only one point is staying in contact, but that's the ulna that's,
Right,
okay.
right, right. Okay. If we look at the end fields of the osteokinematics, we look at movement exclusively of the radial ulnar joint. In supination, the end field is going to be firm. In pronation, it's either going to be firm or hard. Okay? Why either firm or hard? Depends on how much soft tissue is present, right? If someone, as we go into full pronation, we start abutting the distal radius against the ulna as we go into full pronation. Okay? If there's a lot of soft tissue present, you may have more of a firm end feel rather than a hard end feel. Depends on that person's anatomy. Okay? There's variation between individuals. Okay? As we go into full supination, it should be just a firm. You should be encountering the ligamentous restriction when we go into supination. As opposed to in pronation, you may actually be contacting the distal radius with the distal ulna. And you'll get more of a firm end feel, bone on bone. Yeah, Roger.
So the reason why the supination is firm is because of the ligaments?
I'm sorry?
Is the reason why?
Because of ligaments. Yeah, anytime you have a firm end feel, it's telling us that what we're feeling is restriction from ligament. Okay?
Any specific ones, or is just like all the ligaments?
The radial part, we'll look at those ligaments in a second.
All right.
Okay, humeral radial ligament, okay, we'll talk about those in a second. Okay, but again, in supination, we should always feel a firm end feel. As we pronate, it could either be a firm or a bone-on-bone, bony or hard end feel. If we're trying to examine the elbow forearm complex, that should always be done with the elbow in flexion, not full flexion, but mid-flexion. Okay? We do that because we don't want to see a lot of substitution from the shoulder complex as we're examining that individual. So you're always going to want that elbow in flexion as we're examining, some degree of flexion. So this proximal radial ulnar joint, if we look at the arthrokinematics, again, it's a pivot joint, also known as a trochoid joint. And again, you've got that convex radial head. We're looking at the lateral portions. If you hold up your radius, the most peripheral portion of that radial head is convex, round, circular. And it's articulating with a concave radial notch on our ulna, or ulnar radial notch. Okay? That radial head is held tightly, should be held tightly, against the ulna by the annular ligament. That's our primary ligamentous structure that's creating stability of that joint. Remember, However, it's a very mobile joint. There's very little bony congruency between either the radius and the ulna or the radius and the humerus. It's almost entirely dependent on ligamentous structures, therefore a lot more mobility at the sacrifice of stability. But this is a very strong ligament, the annular ligament. And that radius is spinning within that annular ligament as it articulates with the proximal ulna. Okay? So if we have disruption of that annular ligament, we're going to lose any stability that we have in that proximal radial ulnar joint. Very unusual to have any rupture or disruption of that annular ligament because it's so short and strong. Again, the shorter a ligamentous structure is, generally speaking, the harder it is to rupture. The longer it is, allows more mobility, but is more prone to rupture. There's a lot more excursion possible in those longer ligaments. Shorter ligaments create greater stability, all right, and are harder to rupture. Okay? As we look at the arthrokinematics, again, we've got a concave ulnar notch on a convex ulnar head of the distal radius. Okay? With supination, you're going to get a posterior roll and glide of the radius on the ulna, and it's the reverse for pronation. This is the distal radial ulnar joint. Okay? You've got a radius moving over an ulna distally. Proximally, all that's occurring is spin within that annular ligament. As we move distally, you're getting a lot more excursion of that radius over the ulna. Okay? And distally, that radius has an ulnar notch. You identify these structures on your bone again. And that is a concave structure moving on a convex ulnar head, distally. Okay? Again, just as we said with the proximal radial ulnar joint, proximal and distal radial ulnar joints are both highly dependent on soft tissue for stability. There's very little, if any, bony congruency in these joints. So again, any disruption of the ligaments is going to have a huge impact of the stability of those joints. And it's therefore going to impact total motion of the elbow forearm complex. Right? You're losing stability, you're going to lose motion. Okay? Functional motion. You'll be able to mobilize like crazy, but that's all the accessory motion. Okay? Proximal radial joint stability, again, that annular ligament plays the greatest role in stabilizing that radial head against the ulna. Lateral collateral ligament also provides stability proximally. The oblique cord is a specific limit. You're not going to identify it in your lab. Okay, we're not looking at that. But the oblique cord ligament provides a lot of stability at the proximal elbow forearm complex, along with the quadrate ligament. Okay? So that's the entire elbow forearm complex ligament stability. We're going to look at the distal radial ulnar joint in a lot more detail when we get into the wrist and hand, but it's important to note that as we look at that distal radial ulnar joint, there is additional, we said it's both of these joints, proximal and distal, are dependent on soft tissue. Proximally, primarily that annular ligament, encapsulating the radial head. And as we move distally, there is an articular disc, referred to as the triangular fibrocartilage complex, or TFCC. Has anybody heard any references in any of your clinicals?
Yeah.
Yes? Do they do a lot of treatment of hands and that kind? Yeah. So the TFCC is fairly frequently injured, okay? Because of its location and the fact that someone is maybe using a lot of hand motions, wrist and hand motions, that could cause damage to that TFCC. Now, you're going to hear a lot more reference in clinics where they do a lot of hand rehab. Okay, whether it's a hand therapist or a clinic that sees a lot of hand patients, wrist and hand. So that TFCC, which functions as a disc, even though it's really not round, it's triangular, okay? But it is interposed between two bones, therefore we consider it to be a disc, okay? There are also dorsal and palmar radial ulnar ligaments, okay, that are stabilizing the radius against the ulna on the palmar aspect and the dorsal aspect. There's also an interosseous ligament between the radius and the ulna. Where else do we have a prominent interosseous ligament that you probably made reference to at some point?
Tibia, fibula.
Between tibia and the fibula, right? Yeah. And we're going to be looking again at that more when we start getting into the lower extremity. Okay. Anybody know what we call an injury to the interosseous ligament? Have you talked about that? Any interosseous ligament, not just that between the tibia and the fibula. You remember? Heard the term diastasis? Okay. So if you've got two bones that are spread, you will refer to that as diastasis. Okay. Ligaments attaching two bones, if those bones are simply spread, pulled apart, if there's traction on the two bony surfaces, where else can you have a diastasis that can occur during a normal human function? Anybody know? Say again?
Diastasis recti
Uh,
during childbirth.
During childbirth, right, exactly, during childbirth, where bones will spread apart from one another, right? So you can have a diastasis at pubic symphysis, pulling bones apart. So you can have a diastasis injury in the forearm. You can have a diastasis injury in the lower extremity, which is known as a high ankle sprain. Right? You're spraining the interosseous ligament. You're spreading the tibia and fibula apart. You're causing that injury that holds those two bones together. So you can see a diastasis injury anywhere in the body, but it specifically refers to pulling bones apart and stretching or spraining a ligament that holds those two bones together. Okay.
Can you have a diastasis of the abdominal wall?
Yes,
Is that bone?
it's right, but it's still pulling two halves apart. Pulling apart.
So it can be muscular too?
Yeah, diastasis really means pulling apart,
Okay.
but this is in reference that we look at ligaments that are holding bones together specifically. Okay. Spreading apart. Yes.
Is that, going based off of that, like when, after childbirth, a lot of, women have like a depth, is that different? Like,
Have what?
like you can actually palpate a depth
Oh,
in
yeah.
the abdomen, that's
Yeah.
how much gapping there is.
Yes. Yes, you've had a diastasis, right, exactly. Spread the tissue apart, right. All right, I'll tell you what, let's quit there before we get in, we'll start getting to the muscles next time, okay?
All right, here we go. All right, we'll do hip today. Triaxial joint, very strong articular cartilage and ligaments. Anterior, you have your iliofemoral, pubofemoral, posterior, ischiofemoral. So for movement, motion of the femur, the convex femoral head slides opposite. Right? So if we're looking for abduction, the slide is inferior. Looking for flexion, posterior. And when the leg lower extremity is fixed, motion of the pelvis, you have the concave acetabulum moving in the same direction. So joint is supplied with mechanoreceptors that respond to positioning, controlling posture, balance, movement. So any pathology there can affect that. So any pathology can affect balance, proprioception, and it also can affect posture, leading to other types of problems. So a lot of people with hip arthritis, you're going to see maybe some compensation for back, some back pain, possible scoliosis. So your anatomy, you have the labrum, okay, which deepens the socket, acetabulum, you know that. I guess what we're seeing a lot more now are these like labral impingements, these hip impingements. You're starting to get like surgery of the labrum. I haven't seen any successful labral surgeries, you know, from the hip. Then eventually what you're gonna lead to the instability and arthritis, so eventually it's gonna lead to hip replacement. I don't know if they're still doing it, but years ago it was a big thing after, like A-Rod had hip pain, and then he had that labral surgery, you know, came back, played a little bit. I don't know where he's at now. But from that, when he had gotten, a lot of the doctors got back into it, and again, I don't know if you guys have seen it out there now. Anybody seeing labral surgery anymore? Yeah, I don't think they're doing as much because the results haven't been that good. So again, any abnormal structure, impaired function, muscle imbalance causing stress to the spine, other joints, so hip pain could cause pain in the knee, vice versa. You know, improper mechanics at the foot can cause the kinetic chain up, put stresses elsewhere. Even, you know, overuse of the tensor fascia lata can weaken the glute medius, causing, again, that Trendelenburg gait or any type of abnormality or change of posture and function. Could also develop a leg length discrepancy, decreased flexibility can lead to poor mechanics, poor posture, and then you can also create that muscle imbalance. So whether or not one leads to the other, do you have like a closing today?
Yes.
That's why you're all dressed up? Oh, so it's not for me?
All right, you pretend like it is.
So it's one of those, like, which came first? Like, did a structural imbalance cause leg length discrepancy, or did the leg length discrepancy cause the muscle imbalance? And again, you're going to, through assessment, you'll figure that out. You know, it's also important, and we talk about the leg length discrepancy, is even if it is some type of muscular imbalance, and depending on the population, then you want to try to fix that. So, like shoe lifts, especially after even like sometimes a hip replacement or a fracture, you're going to get a leg length discrepancy. So it's very important to add that shoelace, that little heel lift, something in the shoe to balance it out so it doesn't create back problems down the road. So tight hip extensors can cause increase in lumbar flexion. Tight hip flexors can cause an increased lumbar extension, increased lordosis. And then a hip flexion contracture can add additional stress to the knee during weight bearing if the knee cannot fully extend. So again, a lot of the muscle imbalance can lead to other conditions. So it's going to be very important to assess, you know, Thomas test, Ober test, look at that posture. Tight adductors can cause the lateral pelvic tilt and then bending of the trunk. So again, if somebody comes in with back pain and you observe the posture, make sure you also assess what's going on at the hip. So anybody with back pain, look at the motion of the hip, Thomas test, and look at the flexibility there. So an anterior tilt could cause low back pain, could cause a hamstring strain, could cause knee problems. Cures, do you have this one?
No.
Sorry. I have so many like different, from like the, you know, working from home, I got so many different like, those like stick things. I don't know which one I use. So, I'll send it to you, don't worry, I'll resend this, I'll resend everything. So it's interesting, like, you know, you guys think, like, who does, like, who's got the six-pack ab going on in here? Anybody? Anybody focus on the abs a lot? Yeah, you like to focus on your abs?
Such stupid simple exercise.
No, but So, like really strong abs, like functionally, what do they do?
More or like jump stabilization.
Do they?
When you're doing like functional
They make you look pretty from the front.
That's all they do. They make you look good. But what happens, so think about it. So if somebody focuses on their abs, like what are you really doing? Look at the origin of the insertion.
Yeah. Posterior pelvic tilt.
Posterior pelvic tilt.
Yeah.
So you're affecting your back more than you're actually helping it, because for years the whole concept was you need strong abs to help support your back. But the abs don't necessarily contribute to the core. It's more of your quadratus, your transverse, your pelvic floor,
Like,
your
don't you
abdomen.
train those while doing similar movements or no?
Do you train them? Well, yeah, you do.
So that's what I'm saying.
You do. Well, however, but you're also creating, like, you're shortening, by focusing on your abs, like, you're really shortening them.
But if you counter that with like back extensions to strengthen the paraspinals and lumbar.
I mean, you can fix that.
Just squat deadlifts will be fine.
I do that too.
And plank.
I hate planks, but yeah.
But we'll get to that. We'll get to the planks. Yeah, so it's interesting. And so when you look at somebody, again, if they work out a lot, they do a lot of sit-ups, like you really observe, their pelvis to tilt. And again, like, well, you gotta work on the anterior pelvic tilt, work more on your back stuff. But again, rotator, doing the healthy stuff,
Yeah.
like the planks, it doesn't make you look good, but you wanna look good or feel good. You get married, you care, you throw a rock out.
No way. That would kill my self-esteem and my brain, man. No way. No way. I couldn't do it.
No.
Everyone says
My wife says if I ever get like a big giant beer belly, she's leaving. Like, I don't care, you can call me vain.
All right, start working on that belly.
Fair enough.
So we see it,
She's
you
a
know.
fit one,
yeah.
right? She teaches Pilates.
Yeah, she's a fit one, yeah.
Just one of you gotta work with, that's all. Gotta balance it out.
Yeah, it's, no. It's gotta be healthy. Up here.
Yeah.
What they say, exercise for like an older, I don't know what the age was, like the older population, like the middle age, like my age on. Like, diet's always important, but losing weight is not as important than exercising. So even if you have if you're what they call fit fat. Fit fat? Yeah, fit fat. Yeah, it's like a term.
That's a new thing, yeah.
So, for you, when you're older, it's not so much about, hey, you gotta lose weight. Well, no. Just exercise. You're better off. So drink your beer and stuff and make sure you exercise. And that'll be healthier than trying to lose weight. Unless you've already, maintained like that, skinny as you can. But, the hypothyroid problems. That was the excuse, my thyroid.
Yeah,
Has nothing to do with the 2 Big Macs you have.
Exactly.
It's the thyroid.
Big ass Dunkin' coffee every morning,
Yeah.
6 sugars and creams.
Yeah. Whatever.
That gets me heated. When people excuse it away with like stupid stuff.
But then I get the Diet Coke.
Yeah, the Diet Coke. It's like, they're up with the regular. Or not at all.
Somebody, I don't know, I'm sure you can see it, like, put Diet Coke or Diet Soda, like on your car.
Yeah.
You know what it does to the paint?
It strips it.
It strips the paint.
Oh, yeah.
So can you imagine like what it does to your body?
Inside, yeah.
Yeah, it's terrible.
Yeah.
All right, so if we have a lateral tilt, could cause iliotibial band syndrome, could cause low back pain on one side, adductor strain, lateral hip pain. So what's important with those slides is going to say, the hip, the pelvis can cause other problems. So again, if it's somebody coming in with a foot problem, look up. If it's somebody with a back problem, also assess the pelvis and the hip structure, even going down. So if you have a leg length discrepancy, whether it's functional or structural, you can get a lateral shift, lateral bending on one side. And again, we always like homeostasis, so somebody has, we talked about with the shift from a low back pain, but if somebody has a leg length discrepancy, and again, after somebody falls, they have hip surgery, a fracture, guaranteed they're going to have a leg length discrepancy. And anything less than 1/2 of an inch is not as big of a deal. But you might get an 1 to 2 inch leg discrepancy, and they're not going to walk like this. They're going to want to shift, so they're going to develop a scoliosis. If they're born with coxavalga, that larger angle of inclination between the femoral neck, coxavara is a smaller angle, anteversion, where you have the internal rotation. So if somebody has excessive anteversion and they have internal rotation through the way the acetabulum is, what's the compensation below that? So if they're internally rotated,
External rotation.
what's external rotation where?
On
On the tibia, what's going to happen to the foot?
inverted.
Inverted or pronated,
Pronated, yeah.
right? So that's what you're going to look at. So you want to see if that's structural, or again, the only way you're going to know if it's structural is through X-ray, or if it's muscular. We can certainly tell if it's muscular. So if somebody comes in, a runner, who has pronated feet, we want to look at the hip. We want to look to see if the internal rotators are stronger, or tight, external rotators are weak, and then to focus on the foot, we can strengthen those hip muscles. So a coxavalga, that large angle of inclination, coxavara is a smaller angle of inclination. Again, that's going to could cause any type of leg length discrepancy. So we measure umbilicus to medial malleolus, try to find the same point throughout. The true leg length discrepancy is measured through an X-ray, where they could actually measure the bone there. Our disorders: osteoarthritis, degenerative joint disease from any type of abnormal stress, trauma, aging, obese. Right? Yeah. Your back creaking there, or the chair? Getting old? This is more meat on you. So you have your necrosis, your hip dysplasia, the child as they get older, it breaks down the articular cartilage. Usually seen with pain in the groin, possible L3 dermatome. So the differential diagnosis would be any type of back pain, referred pain to that hip. You had stiffness, loss of range of motion, usually internal rotation, develop an antalgic gait. And a lot of times you'll see that lack of hip extension during gait, again, because of the decreased range of motion, the antalgic gait is painful. Also impaired balance and posture. So we can exercise these patients, we can treat them. Patient comes in with arthritis, trying to push off the hip replacement. Try to maintain as much mobility as you can, much strength as you can. But again, we're not going to reverse that arthritic process. Patients might go and get those cortisone shots. You guys know Synvisc injections? Synvisc, anybody hear that? So Synvisc is sort of like that gel that they put, they see it a lot in the knee. So it's like a hyaline cartilage gel where they inject into the joint to try to lubricate it. Basically you're buying time. Doesn't really, the long run doesn't do much. So these come from, like, roosters and like the combs of roosters. It's a gel in that rooster's comb, and that's where they get it. And then it ends up being like a lubricant for the joint. How anybody would figure out like a hen or a rooster could create something that could help like your joints. Crazy. I said 2 trucks driving up 21. Anybody driving down 21 around like 7:15? They must be coming from Newark. 2 like trucks loaded with chickens. And like the sides are open, so you see like the feathers like flying. Yeah,
Probably going for that injection, man.
they are. They're going up to the medical shop there. Well, I guess they get, part of it goes to the injection. The meat then goes, to the butcher. And then the bones go to McDonald's for chicken fingers, chicken nuggets. Or dog or cat food, right? That's what you get.
It's true.
The ground up chicken bones.
Scraps.
Yeah. So again, conservative treatment's gonna be exercise, aquatic therapy is pretty good, but you're not really gonna change the arthritic process. Mainly you're gonna see the hip replacement, whether it's a total hip, whether it's a hemiarthroplasty, where they would just replace, say, the arthritic part. If the acetabulum is still intact, they're just gonna replace the femoral head. And then you also have a resurfacing. We'll show you that. So there's your hip replacement. So what they would do is, with the hip replacement, they'll cut right superior to the greater trochanter. All muscle stays intact. So they're not bisecting or resecting any muscle. They do cut through the glute medius, but it remains intact. So it's easier to repair when you go along the fibers than if you have to cut lengthwise. They would bore out the acetabulum, sort of drill down into the femur, hammer the stem in, put a little plastic cup in for the acetabulum, screw the head back on, and voila, there you go. So, pretty simple, really pretty simple surgery. Takes them 45 minutes from opening to closing. It's so easy nowadays. Whether they do it inpatient, outpatient, but again, you've seen it. They're up and walking the next day, or they're sent home the same day. So again, it's pretty advanced. So our goal is to prevent complications, regain strength and mobility. Obviously, you have your precautions for the posterior lateral approach. No 90 degrees, no internal rotation, no adduction. But what's also important is when you're walking the patient, when they turn, because if it's a right hip replacement and they're turning to the right, you're getting internal rotation there. So also make sure that when they are walking, that you have them with the legs. We worry so much about them being in bed or transferring, but it can also occur when they're walking. A hip resurfacing is where they're just going to sort of shave down the femoral head. Take your femoral head, they'll just shave it down, but then they'll just put a smaller stem with the head into, if the acetabulum is not affected, right, without anything going on to the acetabulum. A lot of times we'll do this with a younger person, because then what can happen, after a while, we're supposed to have 10-year lifespan on this. Like this is what I have in my right hip.
Yeah, how long has it been with you?
15.
15?
Wow.
15 with, half marathons and, hiking. Feels great.
Strong.
You know why? Because I'm not doing sit-ups, I'm doing core. I'm doing planks. That's why. It's not even here to appreciate it. Damn it. No, so the thing about the resurfacing is, if it fails, and it had failed for a lot of people, but again, more the younger, they're back in the younger population. If they need a full hip replacement afterwards, they can just chop the regular bone like they were doing a normal hip replacement, so it's no big deal. Fractures cause from osteoporosis, falls. So here's the question: do you fall and break your hip, Or do you break your hip and then fall? What do you think? Does the hip break and then they fall, or do they fall and then break their hip?
Both ways.
There you go. You'll never know. You can't do a study on that. But from osteoporosis, the older population, yeah, there are times when even just standing, they can fracture their hip. So for fractures, surgery would be either ORIF. They would go in and plate it, pin it, screw it. If it's depending on if they where the fracture is or how much is damaged, they do a hip replacement or even just a partial hip replacement. They would just fix the femoral head, cut up the femoral head, but keep the acetabulum as is. With the fracture, again, you can have your limited joint mobility, limited range of motion, muscle weakness. Goals are the same, prevent any type of complications, so up and moving, depending on what the orders are. For some patients, a hip fracture with an ORIF is going to be non-weight bearing for 6 to 8 weeks, until then you're working, strengthening up until that point, and then get them walking again. But if it's falls, make sure you incorporate that balance protocol as well. Overuse, you have your tendinitis, like a trochanteric bursitis, IT band, rubbing over. The bursa can cause irritation, tightness of the quads, a runner, a biker, and that type of stuff. That overuse can cause the bursitis. Usually pain over the lateral thigh to the knee, the IT band rubbing over the trochanter. Differential diagnosis, anybody with low back pain, L3 to L5, and if we know our L3 dermatome coming across the hip, that referred pain could cause hip problems. Or the hip pain, somebody goes to the doctor because they have hip pain, without doing an MRI, knowing if it's the back, a lot of times they can be diagnosed with that trochanteric bursitis. If it is bursitis with anti-inflammatories, modalities, it should clear it up. If it doesn't clear it up over a couple weeks, then you want to look at the back. I always do a back assessment anyway if I see a diagnosis of trochanteric bursitis. With a lot of the orthopedic doctors, you got bursitis, they're going to give a cortisone injection. Again, it should clear up very quick. If it doesn't, I look at the back.
What would your back assessment look like?
I just like a regular back assessment. So I'll do, like your repeated flexion, repeated extension. I'll look at the SI, the history, and just see if there's any difference there. And then I'll really look at the piriformis. Because again, a lot of that, piriformis inserting into the greater trochanter. If I feel that thing is like, in spasm or tight, then you really dig your elbow in there, try to release it, and then a lot of stretches there. And it usually clears it up. That's why, again, I found more back stuff works with this trochanteric bursitis than just focusing on the head.
Would you incorporate more core exercises or like abdominal?
I love it. See, I do sit-ups. Yeah, I know. For back pain, all sit-ups. Yeah. But not too many sit-ups because you want to avoid the STNR.
Okay. Good. You're gonna have these jokes all year.
Never gets old.
Never let it go.
No, never.
Joe, gotta mind the arms.
So, so differential diagnosis, L3, L5 derangement, like referred pain from your deep external rotators, from your SI. So palpate the SI evaluation. Look to see if there is that leg length, right? Have them supine, look at the malleoli, bridge up, and see if there's any change there. Because again, a lot of times that referred pain is coming from the back, not necessarily the hip. If it is, soft tissue massage, any type of stretch, and then a kinetic chain evaluation. Also have a psoas, bursitis, check with the Thomas test. Anybody ever have a hip flexor or psoas release? You guys had it? Or you seen it?
I've done it.
Done it, and
You
I've
got it done
done
to you?
Yeah.
Brutal.
Yeah.
Yeah,
Same, I did it and had it done to me.
yeah, it's brutal.
It's bad, it's like much more ridiculous in that area.
Alright,
Like, yeah, like that thing. But yeah.
so, like hip, so really, when we look at the posture, so with most of our outpatient, we're gonna see back, but when we look at the posture and how your hip flexors can really affect your posture, can lead to back pain, can lead to hip pain. If those muscles are tight, and we sit a lot, you do like a psoas release. You guys know your origin of your psoas. So they would go in, they really dig in very deep and just press on it. And you can even do like a cross friction type of thing. But it is very deep, it's very painful, but it is very effective. I don't know how you felt afterwards.
I felt great after.
Yeah.
The turnover on it is phenomenal.
Yeah.
9 out of 10 times people are like, oh, I feel so much better.
Again, it's very painful while you do it, but once you can if you can get that psoas to release, it's very, very effective in helping in hip and back pain.
Do you do it while on the stretch? Do you put it in the stretch or do you?
No, I just have them supine, try to have them relax. Yeah.
I think there's a device now there's just 2 points,
Yeah.
and you just lay on it. It's called the Sorite. Yeah,
I never saw it.
it's just like now that yeah, but the thing is, it looks invasive because it's just 2 points. Yeah, I mean, you could bring it up on the screen.
I'll bring it up. I'll bring it up.
Yeah,
Maybe
so-
I'll buy it for
I
here.
have one, I'll bring it in.
You
Yeah,
bring
you
one
can
in.
bring it in and
It's awesome.
I've never seen it.
It's
They try to, it's like a
This
piece of
thing.
plastic.
You kind of lay on it.
yeah.
All right.
Yeah, it's really
All right,
good.
bring it in. All right, we'll try that out. I've never seen that thing.
You didn't give in to the.
That's part of that. That's like, I think the obviously it's very important to educate your patient. Like, there are a lot of like very effective but painful techniques that if they can get over the pain, like the long-term benefit is going to be so much greater. So, but you got to let them know that it's going to be very painful. I mean, I don't really foresee doing it with an older population. Maybe more of the outpatient, younger, weekend warrior, somebody that really knows their body. With overuse. All right, so hip assessment. First thing we're going to check is posture. Okay, we're going to look at the back, look at the level of the iliac crest, measure leg length, measure strength, do our flexibility stuff with our our Thomas, our favor. But then we also want to look at the kinetic chain, look at their feet, and see if their feet changes anything, moving up. And again, very important, if somebody comes in, regardless of what the condition is, just don't isolate on that condition. So if somebody comes in with knee pain, IT band syndrome, patellofemoral pain, they're all saying it's coming from the hip now. Even a lot of foot problems, all coming from the hip. And that's why, to me, it's important that glute medius, so, go here. A lot of times, it's not necessarily the strength of the glute medius, it's just getting it to turn on. And so, the importance of the glute medius to posture. And again, so if somebody has that weak glute medius and they have a slight trendelenburg, you might even notice it. It's going to affect the biomechanics of your gait, which will affect the biomechanics of the back, and again, the entire kinetic chain. So I think a lot of emphasis on really how to strengthen the glute medius for back pain, hip, knee, foot problems is very important. So a bunch of studies, you're really trying to quantify what's the best way to strength. I can send this if you guys want to read it, but yeah, I'll send it all to you. So one of the studies showing the best way to strengthen the glute medius. And this measures the maximum voluntary isometric contraction within EMG. So I know a lot of times we do sideline hip abduction, we do the sideline the clamshell, lateral step-ups, and they're all good. But to really be effective, the best exercise they call side bridge to neutral spine position. So it's really a side plank. We can do it in lab today. Side plank, and you're dropping down. Most effective way to strengthen the glute med. So with a lot of the younger hip replacements that I've seen, that I see now, what recently has been, like I had, I think it was like a 45-year-old woman, I had a 48-year-old guy, but it also depends on their activity level. The woman was a black belt in jiu-jitsu, so she was used to fitness and working out and pushing herself. The other guy was a basketball player, went to the gym. So obviously you want to know who and what to do. So with the hip replacement patient, I'll start planks after the first week, but I'll have them plank on steps just to start getting the core firing. I'll have them do some side planks on their arm. So with the exercise they're showing, the one that created the most contraction was, again, the side bridge. Single leg squat was second, single leg deadlift, pelvic drop. You guys know that pelvic drop where you're, so you have them like at the edge, like that hip hike. So, another great exercise that you have to have your patient do to really strengthen.
Can you zoom in a little bit?
I'll send this to you. This is as best as I don't know if I can. Can you?
Yeah.
Oh. There you go. So side bridge or plank, single leg squat, single leg deadlift, pelvic drop, sideline hip abduction, wall squat, then lunges, universal bridge, step up. So your clamshell, 30 degrees, not as much as the others. Again, you can still do it. These are all still effective. But moving down, bridges for the glute med, very little. Lunges, not as much.
Yeah, I think they just use it because like PT places are just so damn busy.
It's
a really
easier.
easy one to do, I
It's
think.
a lot easier. It's easy to do the lunges, the clamshell. They have side lateral stepping. They have lateral step up. Again, doing
with the
the lateral stuff.
Yeah.
And so I'll send you guys these sheets so you have it. I'll send you the article. The other thing I wanted to show, because I know what became big is also the difference. So patients are going to ask you, the anterior versus posterior, and a lot of it really depends on the doctor. So the studies are that in the very beginning of the anterior, they felt that your return was a lot quicker, that the benefits were greater than the posterior. The incision is a lot less. Let me tell you what the difference is. Your incision is a lot less. You're not really moving as much muscle and tissue, so the recovery was a lot quicker, a lot easier. There really is no, the study showed that there really is no difference between the anterior and the posterior. I do know I have seen a couple anterior where they had some femoral nerve neuropraxia. You saw that? Did you see that?
We talked about this in our clinic, it's pretty much that, it's just whether or not, it's how close it is to nerves and arteries, as opposed to going posterior.
to shift away from posterior, maybe because of the fear of dislocation. But you're looking at like a 2% rate of dislocation on hip replacements. And, and I actually asked, I didn't mind talking to the doctor about, like how important are these precautions? And he's like, the precautions are really only important for, people that are, that don't have cognitively, or those that have some type of like drug or alcohol abuse is what he said. Because otherwise, like I'm not really so worried about the precautions because the dislocation rate is so minor. But they teach them. But again, the difference between the anterior to posterior approach, we have a lesser scar. I know the position-wise, supine on the table as it compared to sideline. You don't have those precautions. Yes.
Are those the only two approaches?
Yes.
I've seen a patient that had it laterally, and her only precaution was hip abduction.
So it's just lateral?
Yeah. Like with like that. Yeah, my I never saw it either. Really.
Yeah.
Okay, that's new.
Yeah, I've never seen that.
Yeah, so she didn't have the normal precautions. The only thing was because it was on the side, she couldn't do hip abduction.
I guess we're trying to reinvent the wheel.
And actually with those precautions, there was an in-service at Hackensack Hospital that the therapists attended, and they said that now they're changing the precautions.
For the anterior approach?
For the posterior approach.
Two.
So basically, it's not only that you can't do flexion more than 90, abduction and internal rotation, it's all a combination of those. So you can't do more than one of those at the same time.
Okay.
So
Yeah.
but I was like, if they're abducted and they're not internally rotated or flexed, that's still contraindicated. So I don't understand why that's appropriate. Because they're like, oh, if they abduct or if they're flexed, just without the other two movements, it's okay. But it doesn't make any sense because
I guess vulnerability.
there was a patient who was clearly flexed more than 90
And
degrees,
happened.
and I said to the therapist, I'm like, I'm sorry, like I'm not an aide, but I was like, hey, like, should we instruct them not to break their they're like, no, it's fine, and I'm like, well, we've taught otherwise.
Yeah.
I saw it pop out once. And I mean, I remember Cheeto tells you the story. And this is the guy after. I treated him when he first had it. And this is like a year, not 2 years after replacement. We were at the gym, and he went down to pick up dumbbells like this. So he was doing flexion, interrotation, adduction all at the same time, and it just popped out. I can do this all day long and not have a problem. Why him? Who knows? It just maybe gave way, no idea. But again, I tell patients, you know what, for 6 weeks, adhere to these precautions. Afterwards, keep them in mind, but if you go down and tie your sneaker, you pick something up, nothing's going to happen. Just make sure you get it really strong. So in terms of anterior versus posterior, in terms of anterior versus posterior, again, one study that they came up with. So basically, the outcomes are the same. So it's not the surgeon. I mean, it's more the surgeon than the approach. So people talk to you about why anterior or posterior. It's just the preference of the doctor. I don't know. You were good?
Yeah, I'm good. Good. Yeah.
All right. All righty. So again, I'll send you guys this article. There's 2 articles that talk about different strengthening. But I know since reading this last year, I've incorporated a lot of the side planks, a lot of planks with hip replacement patients. Good. Questions?